Three, two, one. We are live.
So, good evening, everyone. Sailing through waves is no longer a leisure sport or a hobby to pursue. As we all have been forced by nature to sail through the wave of present pandemic, COVID waves. But is it a new thing to face such crises even of this magnitude? Yes, it can be a new thing for our generation, but certainly not for the humankind. Going not much far, merely a century ago, Spanish flu of similar intensity was occurred. In that phase also, April was the cruelest month. Important thing here is to take learning from such past experiences and even mistakes to craft a better present or a future response. But today, as a human, a seemingly most intellectual species on the earth, if we ask ourselves, do we have that aptitude of learning from the past and not committing mistakes? Did we learn our lesson of not sidelining the science? An unfortunate answer to all this would probably be no. By and large, we all were sitting comfortable and lowered our guards with a hope that there is no virus around. And suddenly, all our hopes and aspirations got vanished in the cold of the beautiful winter under the huge pressure of deadlier second wave. And we have witnessed once again the cruelest month of April 2021. Current situation is beyond heartbreaking. It has imposed a load to healthcare workers beyond the stretch of any imagination. But like true saviors, you all have stood up against this giant challenge like an unflinching wall. As a result, we are witnessing a downtrend of COVID positivity. But more important learning of this time, which people have started to realize, is science must be the heart or core of any response to tackle such health related exigency, and it can never be sidelined. One another thing of similar importance is other health issues should and can never be taken for granted, be it any situation like COVID itself. For an example, cardiometabolic disorder. Not showing wave pattern doesn't mean it is not pandemic. It is a silent tsunami which is continuously ascending without showing any respite. Again, responsibility of confronting this health concern lies on the broad and strong shoulder of the healthcare professionals like you. To avoid this tsunami, we all need to constantly elevate patient care with careful understanding of emerging evidences, and continuously learning from the experience of experts. Keeping this goal in mind, we are conducting the Cross Connect for last 6 years, and it has established as one of the go-to conference for the Indian doctors. Cross Connect has been a unique platform to the Indian clinician for last so many years, which is preliminary based upon the thought of bringing cross therapy experts together for churning the science and update of prevailing clinical concerns, which shall ultimately contribute to the society in terms of improved healthcare management. Due to ongoing situation, we also went digital to keep cross specialty discussion live from last year itself. And this year, we are back with yet another scientifically distinct program. And it's my honor and to privilege to introduce you the creator of this program. Let me welcome the craftsman of this event, two prominent figure of the Indian medical fraternity, Dr. Amrish Mittal, an eminent endocrinologist from the Delhi, and Dr. Ajit Mulasari, a renowned cardiologist from Chennai. So no word are enough to describe a stature of our course director, but still let me give my best to give you all a glimpse of it. Dr. Amrish Mittal is a present chairman and head of endocrinology and diabetes division at Max Healthcare. He is a Padma Bhushan and BC Roy awardee as well as member governing council of Indian Council of Medical Research. Dr. Mittal was the first DM endocrinology from All India Institute of Medical Science. He is the past editor-in-chief of Indian Journal of Endocrinology and Metabolism. He is a past president of Endocrinology Society and he is a board member of the International Osteoporosis Foundation. He recently received the IOF President Award as well as the Fogarty Fellowship from the Harvard Medical School WIDF Outstanding Investigator Award for the Diabetes Research and Boy Fame Award from the ASBMR. So welcome you, Dr. Amrish Mittal, sir. Our another course director, Dr. Ajit Mulasari, sir. He's a director cardiology. He's a director cardiology of the Madras Medical Mission, Chennai. He's the founder member of STEMI India and founder trustee of Sankalp, an organization for children with learning disability and autism. Dr. Ajit is a adjunct faculty to the case Western Reserve University, Cleveland, as well as the adjunct faculty at Department of Biotechnology, IIT Madras. He has the Lifetime Achievement Award by the Dr. MGR Medical University by Governor of Tamil Nadu, Melvin Jones Millennium Award by the Lions Club International, and the Charkha Award by Rotary Club of Dundee. Dr. Ajit Mulasari was also a primary investigator for the various clinical trials like Extractimi 25 Olympia, Texas Registry, and the Spirit 5 Registry, and so on. And he has more than 200 papers published in various national and international journals. So welcome you on board, Dr. Ajit Mulasari. So, and this speaks the volume about our course director. And with this, now I would like to request Dr. Amrish Mittal, sir, to give a welcome note and for the further proceeding. Over to you, Dr. Mittal, sir.
Thank you very much. It's always a pleasure to be on Cross Connect because of the high quality of speakers, program, and also the wide reach this has. So when one makes the effort, one knows it's reaching the right people. I'm really happy to have Dr. Ajit Mulasari as the course co-director for the cardiology section. The important point in this whole COVID pandemic is that it has taught us many ways to do things. And my colleague and eminent endocrinologist, Dr. Subhankar Chaudhary, will be telling us about how to deliver chronic care, how to deliver patient care in the setting of the COVID pandemic, where direct access may not always be possible. Everyone knows Dr. Subhankar Chaudhary, and we know that he is the chief of endocrinology at the PGI Calcutta, and as a legacy of huge number of students who are spread across the country and delivering endocrine care. I think that's his single most important legacy, other than his own publications and his own outstanding oratorial skills. So I think as a teacher, he is very well respected and renowned. And what I will be talking about a little bit today is about preventive strategies for type 2 diabetes complications. Again, we cannot take away anything from COVID these days. And as was briefly mentioned, it's very important to understand that the term syndemic is actually most applicable here. And it's important to remember that the people who are suffering from poor outcomes in this pandemic are the ones who have chronic conditions like diabetes, hypertension, heart disease, chronic kidney disease. Our own study last year showed that in the first wave, out of 401 consecutive patients that we studied, more than 50% had diabetes. And the poorest outcomes were those who had multiple comorbidities, diabetes with hypertension, with heart disease, with CKD. The more the number of comorbidities, the poorer the outcomes. So even more than in regular times, the importance of looking for diabetes complications comes to the fore. So we'll have two talks in the endocrine section. I'll be talking about how to screen people with diabetes, and Dr. Subhankar Chaudhary, my friend and colleague, will talk about delivering diabetes care in the outpatients using face-to-face versus digital, what he calls the phygital way. So I think we can actually start because we're already behind time. Is it okay?
Yes, sir.
So shall I share my slides? Are those visible?
Yes, the slides are visible. Yes.
So over the next 20 minutes or so, I'll be talking about screening for diabetes complications, which means that when we see people with diabetes, we are looking at much more than glucose. We are looking at the fact, what is the purpose of treating diabetes after all? The purpose of treating diabetes is not to lower the sugar alone. It is to look for complications and nip them in the bud. So while there will be a broad upstream approach, which includes correction of all risk factors so that we can reduce the risk of complications, but there is a second level approach, which means, yes, we will look at all the risk factors and correct them, but we also have to look for any beginning of any complications. And as we know, in people with diabetes and even otherwise sometimes, these complications can creep upon us unrecognized without any symptoms. So how should we screen for diabetes complications, and when and how? Why should we worry? As I said, type 2 diabetes has an impact on longevity, and you can see, depending on the age at diagnosis, you will find that people with diabetes actually lose some life years. So if you look at this age at diagnosis of diabetes, you can if someone is diagnosed with type 2 diabetes at a very young age, at 45 years and at 65 years, you lose that many years. Maybe if you're diagnosed very young, 10 to 12 years. In a more typical diabetic, it's about 7 years, 6 to 7 years of life years lost. So I think that's really, really important. And you can see, again, median survival by age, this is control, and this is type 2 diabetes. So as we increase the duration of diabetes, or looking at it the other way, as we develop diabetes at a younger age, we find that we are actually living less. And this is 2019, so this is with fairly good management. These numbers would be horrendous 30 years ago, when management of diabetes was not so advanced. So we also know that the oversimplification that we've been teaching and we have been taught over the years of a micro and macrovascular disease is very important, and to understand that there is actually a huge overlap there, and we are traditionally taught macrovascular disease, heart and peripheral vascular disease, microvascular disease, eyes, kidney and nerves, but it's actually not that simple. We do realize that there is a huge overlap here. Factors like endothelial dysfunction and others apply to both equally. The increasing understanding about heart failure, which my expert colleagues will discuss later, actually again brings us to the fact it's not just those large vessels getting blocked causing heart attacks, and it's not, so it's a combination. And also the overlap between kidney disease and heart disease is so tremendous that we do understand that when we talk of complications of diabetes, we are looking at the whole picture and not necessarily straitjacketing them into macro and microvascular. We can be more organ-based rather than vessel-based, I think. So, of course, we know that obesity is a forerunner of type 2 diabetes and also modifies the risks of complications hugely. It is said that if you're able to eradicate obesity, you'll probably eradicate 90% of type 2 diabetes. You also know increasing areas of concern, the fact that people with diabetes have higher prevalence of non-alcoholic fatty liver disease, and those with non-alcoholic fatty liver disease have higher prevalence of poor coronary outcomes or more cardiac events. So very clearly, the whole thing is all overlapping. And we also very well understand now through numerous studies and presentations the importance of overlap between chronic kidney disease and type 2 diabetes. And again, you know that very well. The most common cause of mortality in people with chronic kidney disease is are coronary events. So I think it's again important. And as I already emphasized, heart failure, relatively newly recognized complication of diabetes, association of diabetes, if you like, and which has a significant impact on morbidity and even mortality. So a diabetic patient is stuck. How many things can one look after? Stroke, eye, kidney, peripheral vascular disease, foot neuropathy, erectile dysfunction, cardiac events, dental events. We all know people with diabetes. This is an old slide. We don't call them diabetic anymore. It's called people with diabetes. Basically, could be suffering from all of these. What does that mean? It means to us that diabetes is basically like an index problem that brings the patient to you. Diabetes per se is not that big, it's an index problem. And therefore, all these associations arise with diabetes. And therefore, when someone comes to you with an elevated blood glucose or a diagnosis of diabetes, you have to look at the patient very holistically. Let's talk about kidney disease. We know that diabetes is a leading cause for CKD, undoubtedly, even in India now, but especially in the West, data that came out earlier. In fact, in India, my nephrology colleagues tell me that it is by far the most important cause of kidney disease. Of course, there's a lot of overlap with hypertension. You can't sift out diabetes and hypertension, and often the combination actually plays a very important role in determining the risk of CKD, but it remains a leading cause. And in one observational study published in the IgAM, over 40% of patients of type 2 diabetes in a cross-sectional study were found to have some degree of renal impairment. And when you look again, as I said, ESRD in India and Kidney International, 44% were by diabetes. This is 2006. I'm sure the figures will be much higher now. Also, the problem is that even in the West, there is some degree of lack of awareness about CKD. And if you look at this 15th-month retrospective review of 5,000 patients with type 2 diabetes and diabetic kidney disease done about 10 years ago, published in 2014, if you can see, the blue is undiagnosed and the gray is diagnosed. Overall, 88% were undiagnosed of those who had CKD. And in stage 1, when you're really talking of just minor declines in GFR, most were undiagnosed. And the diagnosis only really happened towards later stages because physicians are too busy, awareness is less, it means additional tests. So quite clearly, a lot of people get neglected in early prevention of CKD. So the recommendations are at least annually urine albumin. We know this, and I don't want to repeat, these are very standard recommendations. Clearly, in type 1 diabetes, you can wait 5 years because you can clock the onset very clearly. But type 2 diabetes, you need to do it every year from the year of onset or diagnosis. And of course, if you have already got abnormalities like urine albumin increase or GFR decline, you should be monitored twice annually. I think this is a remarkable sort of recommendation, and I don't want to go through the whole thing because that will be the whole talk then, but you should seriously look at this. And here what is happening is that when you're judging or diagnosing or assessing CKD, you're doing it by the GFR category and the albuminuria category. And this is the highest GFR and the lowest albumin, which is to the upper left. And this is the lowest GFR and the highest albumin. So you are looking at a wonderful grid of matching, adding two important parameters, GFR and albuminuria, and by that you are able to predict the progression of disease, the seriousness of disease, and also how frequently should that patient be seen. That patient should be seen if he's in this goal once a year, twice a year in the orange zone, thrice a year in the red zone, and 4 times a year or even more if in the deep red zone. And this is important to understand. It's a wonderful guideline to help us treat our patients. And also a lot will depend when you need to get to the nephrologist. This, of course, will vary center to center. But it's very good to know that if you're on the right side of this chart, you always go to a nephrologist if there is severe proteinuria. you're always good. If there is kidney failure per se, less than 15, obviously you are primarily a nephrology patient. Severely decreased, again. So this gives you a fairly good idea of how to utilize resources optimally. And while this may vary from center to center, depending on availability of specialists, I would strongly recommend that we try and follow this paradigm when we are managing renal disease in our people with diabetes. What about retina? I won't spend time on that too much because that's really not too much in our scope today. But yes, we need to do an annual retinal exam for everybody. Very important. And many of you can now use, at least for screening, handheld fundus camera or better fundus cameras that can do non-mydriatic pictures of the fundus, and they can actually help us a lot in deciding whom to refer, whom not to refer. They are not a substitute for a good ophthalmic examination, but given the numbers of people we have to deal with, it's a good idea to have in your clinic a fundus camera, which will do a non-mydriatic picture of the fundus. And then that can be shared with an ophthalmologist, even remotely, and they can guide you whether the patient needs to see an expert or not. And the degree of the frequency of visits, again, depends. Minimal or no retinopathy, 1 to 2 years, minimal retinopathy, annual. And then, of course, it depends on how the patient is. This is a RSSDI recommendation, which is very, very important for us in the Indian setting, right? Then we move to neuropathy. Again, we won't spend too much time, except to say that by and large, doing good monofilament examination, ankle jerk examination, and of course, I've not put that here, but doing a handheld Doppler for the ankle brachial index and just checking that would actually do a lot. You don't need too much technology. People invest a lot and spend a lot in neuropathy screening technology, but a good clinical examination, which does take a few minutes, will actually be usually sufficient to compensate. So the neuropathy, yes, is very important to detect, but it can be done without using very high technology and expensive technology, and just by a good monofilament examination. It's not as good as a bioseisometry, but it's almost as good. So you could do that. I would strongly recommend that we do a neuropathy screen. In my experience, this is the most missed part of diabetic complication screening. Monofilament, bioseisometry, of course, if you want to, and tuning forks, most important. What about cardiovascular disease? A lot of changes there. We know that there is a greater risk of heart disease in people with diabetes. We won't even go into that. But we also know that what is recommended, even in 2021, that in asymptomatic patients, routine screening for CAD is not recommended. So what they are saying is aggressive control of risk factors, which means you control the lipids well, you control the hypertension well, you control the diabetes well. And the use of statins along with good control of blood pressure and good control of blood glucose actually is sufficient, and you don't really need to screen. In the sense, why don't you need to screen? Because you're not going to add too much to the predictability. So even if you may or may not find something, but the fact that if you're aggressively controlling risk factors, most of your job is done. Right? But of course, you will consider investigations when there are any even atypical cardiac symptoms, any history of peripheral arterial disease, claudication, or a routine ECG shows abnormalities, any breathlessness, no chest pain, unexplained fatigue is quite important. Any other clinical signs, you would definitely recommend cardiac testing. But this also is sort of debatable, because when we lose patients to cardiac events who did not have any symptom before that, we are always concerned whether we can, how can we justify this? We're always struggling with this. It's the cost that is one big factor, convenience another factor, and the misleading nature of some of these tests sometimes that actually prevents us from being very, very liberal. But having worked in cardiac hospitals for last many years, I actually we have developed some kind of strategy. But one very good way to look at it is this recommendation from the European Heart Journal, which I really like, and my cardiologist friends are very familiar with this. No diabetic is low risk. A moderate risk is a young diabetic with duration less than 10 years. A high risk, duration more than 10 years, and no evidence of other target organ damage or other presence of other risk factors. Right? Other risk factors, proteinuria, renal impairment, left ventricular hypertrophy, retinopathy. Sorry, other risk factors means age, hypertension, dyslipidemia, smoking, obesity. And target organ damage means proteinuria, renal impairment, LVH, or retinopathy. So if you have hypertension, dyslipidemia, smoking, obesity, if you have additional risk factors, smoking, we often forget. I also actually include family history in this. I think family history is such an important predictor that I would, tend to investigate much earlier in those. And very high risk, we all know. We have other target organ damage, 3 or more major risk factors already enunciated. So I think this is a very good way to look at your patient in the OPD. Where does your patient fall into? Which criterion, which group? And based on that, of course, I've already said, we all do this. As I said, risk factors, we already enunciated those. And what test should we do is an issue. I'm not going into that today. My cardiology colleagues will help me, but we have somewhat settled in these high-risk patients for often using a stress echocardiogram, a baseline and a stress echocardiogram, but that can vary a lot. We am no one to recommend that, but stress echocardiography we find has been definitely more useful than treadmill testing, but this is only possible when you're working in big hospitals or when you have that infrastructure all the time. So one has to be careful about this. One can take the path of not doing anything if someone is asymptomatic, but I think stratifying into different risk categories and then being a little bit more liberal with the investigation is probably more practical in our setting. Of course, you have to manage hypertension, you have to manage lipids. I won't waste time on that. And you can use many risk systems. The QRISK-3 and the UKPD as risk as what has been recommended. You can do that if you have the time. You can use risk systems, but I actually find this very convenient to use in clinical practice. And what about the newer complications of diabetes? We have like 2-3 minutes to explain that to you. Newer complications of diabetes. They're not newer complications. They're just that we are paying them attention, and Shubhankar will testify during our times, these complications of diabetes ended where I've ended just now. But now we know that the liver is a major organ that is involved in not just the pathophysiology, pathogenesis, but also in the association of disease or complications of diabetes. We know that NAFLD is common in India. We also know that a lot of it is just fatty liver, nothing more than that. But we also know that some of them progress to fibrosis. And I think that is very, very important to understand, because this doesn't matter. But who's going to go here, and that really matters. Because the numbers of people are so high in this, that even if a small percentage reach here, you will still get a high proportion of patients with chronic liver disease, decompensation, and even hepatocellular carcinoma. But what is important to understand is that liver fibrosis is a dynamic situation. Until medium levels of fibrosis, you can have reversibility. When we were students, we were told once fibrosis sets in, it's irreversible, it progresses to cirrhosis. But that's not true. A lot of data has suggested there is a dynamic fibrosis in the liver. So if you pick it up early, it's very, very helpful. Just to give you an idea of the kind of numbers we're talking about, if you talk of 73 million, probably 77 million or more, you would still have 40 million NAFL, 27 million NASH. Look at the numbers there in India. Okay. So, and you can do many tests to figure out. So what should we do? Our study with MRI, proton fat fraction, it actually was fairly well received, especially the impact of SGLT2 inhibitors and GLP-1 on this, but that's not possible for you to do in clinical practice. So what should we do as clinicians? How should we assess this? So one of the ways to do it is to do a scoring system. You can use any of the scores you like. We've collected some of them. We often use the FIB-4 score. Others are even simpler, AST-ALT ratio. But these are things you will do in all your patients. You know the age, AST, ALT, and platelet count, and there's a formula for calculating. There's no time to discuss all that. Based on the FIB-4 score, why are we doing all this? Why should we do this? Why should we worry? We should worry because just diagnosing fat in the liver has little significance. if we cannot pick up the fibrosis. So it's important to predict from our pool of fatty liver patients who is the one who has fibrosis or potentially has fibrosis, who requires further investigation. And one paradigm that we made when I was at Medanta with my young colleague Shafiq Kuche, who has taken a lead in this area, is basically when we have type 2 diabetes and suspected an AFLD, you do a FIB4 score. And if you're below a particular level, you don't require too much. If you are above a particular level, you should do what is called a FibroScan, VCTE, and based on the results in FibroScan, you should intensify or manage. And this is available in everywhere. So you can look at this, or you can ask me for it if you like later, but it's important. And how you're reaching there is by using very simple clinical parameters. So therefore, a FibroScan can't be done for everybody, but should be done when indicated to make sure that you're picking up those who are heading towards fibrosis rather than just labeling everyone on ultrasound as fatty liver and doing nothing about it. This is very, very important to understand. And the last 2 minutes, if you will grant me, I will talk about the last thing, the most least recognized and the most recently recognized complication of diabetes, and that is osteoporosis. What about fragility fractures in diabetes? They are clearly higher. Relative risk, this is type 2, this is type 1, forget type 1. The relative risk of fractures is at least 1.7 in people with type 2 diabetes. It's usually 2 to 3 times in most studies, but being very conservative using this meta-analysis, you find that it is clearly higher. So what it means is that people with diabetes also have bone fragility. We are not going into details of that, but they have a greater risk of fracture, which means that they require screening for all these things, but also some of them require to be screened for osteoporosis. And I think this is important to understand. The problem here is that people with diabetes tend to fracture at a higher bone density. What does that mean? That if 2 people have the same bone density, one has diabetes, one does not have diabetes, the person with diabetes tends to fracture even if bone density is looking better. So the cutoffs for bone density, the T-score is recommended to change to -2. You know that in bone density, we look at a T-score of -2.5. But here in diabetes, because of the fact that at the same T-score, they tend to fracture more. So they tend to fracture actually at a better T-score. So look at this here. These are purple bars, which are diabetes, and the green bars are no diabetes. And this is the T-score going down from left to right. For every T-score, the risk of fracture is higher in people with diabetes. This is hip fracture. This is overall non-spine fractures. So which bar is taller? It's the purple bar, which is the diabetes bar. So if you have a -2.5 bone density, this is the risk in a diabetic. This is the risk in a non-diabetic. If you have -2, this is the risk in a diabetic. This is the risk in a non-diabetic. So the difference is there at every level of bone density. So you cannot use a conventional -2.5 for people with diabetes. And the IF recommends that we should screen all diabetes over 50 and treat at a higher BMD than those without diabetes. Now, this is a hugely draining thing. How do you screen everybody over 50 with bone density? It's not going to be easy in our country, and that too, and then at -2 to start treating. So we've tried to develop methods by which we can, in relatively resource-constrained environments, and we've just recommended this paper just came out like last month, considering the low risk of fracture in early diabetes, because almost all studies have shown the risk of fracture really starts going up at 5 and significantly goes up at 10 years of diabetes. And a resource-constrained environment, we suggest a bone density measurement above 60 for all diabetes, between 50 and 60 for those who have either multiple risk factors or who have had at least 10 years of diabetes. Above 60, all diabetes should have bone density, all people with diabetes. Between 50 and 60, if you've had diabetes for more than 10 years, or you have other risk factors. I think this is a practical suggestion. We don't have data to show that, why 50 to 60, why not 55 to 60? Right? So there is a lot of, but there is some empiricism in that, in this recommendation, but still I think it's clinically very useful. I think this more than 50 story is a bit difficult for all people with over 50 to undergo screening with a bone density. And if you do find a low bone density, you have to treat the person as you would any other person with osteoporosis, and you give the same weightage to a -2 score in a diabetic, then you do to a -2.5. Now, it is it's very important for you to realize this, because you are the people who treat diabetes, chronic care physicians, endocrinologists, diabetologists, cardiologists, everyone treats diabetes. And if you're going to deal with these people, they will not go for a bone density test randomly. If you're going to tell them this is your risk of diabetes fracture, and they're coming to you for diabetes, one of the visits you can slot in a bone density also if they fulfill these criteria. Thank you very much. Some rays of hope in Delhi. This is a morning walk today. Delhi is beautiful this time of the year, with the amaltas all falling on the ground and the sky being blue. There have been rains here last 2 days. Thank you very much.
Thank you, Dr. Mithal. Now I would like to request Dr. Mithal to introduce our next faculty. And
I think I've already introduced Shivankar. He is one of the country's foremost endocrinologists. We know that very well, most respected for his academic abilities as well as clinical skills. He right now heads the Department of Endocrinology at the PGI-MER Calcutta, where he trains the largest number of students across the country in the PGI-MER Calcutta. So huge responsibility and huge accomplishments as a teacher. He edits the main journal of the Indian Endocrine Society of India, which actually I did for many years before him, but he's doing a much better job now. The journal is much better under his stewardship. He's been, of course, past president of the Endocrine Society of India. I mean, all that is not worth discussing. So we all know Shivankar and look forward to his talk.
Very good evening. Thank you very much, Ambrish, for that wonderful introduction. And it's always good to be amongst friends, amongst great people like Ambrish and Ajit. Let me try and share my screen. So I think the organizers should be giving a prize to all the participants who have guessed correctly what phygital means, because when I was handed over this topic, I really had to learn that phygital is supposed to mean face-to-face, a dual mode, a combined face-to-face and digital way. So while we had a wonderful session with Dr. Ambrish Mithal looking at how to screen and when to screen for various complications in diabetes, my task is more process-based, how to deliver care, and I'll be dealing very little on individual drugs, which drug to use and which not to use. And it's all in the context of the COVID-19 pandemic, how to deliver diabetes care. Hope, yeah. So we all know that COVID has wrought havoc across the world. It's brought so much of anxiety, misery, and sadness, so many deaths. But life has to go on. And I think in the last 1 to 1.5 years, I have become adept at online transactions, which I never used to do. I used to depend on my wife for all of these. And then online shopping, which was already growing, has really sort of become a boom now. And nowadays, you even have digital kitty parties. So life is changing with COVID-19, and our medical care also, of course, is changing. And we are really, the medical practice is also trying to orient itself to the new needs. And if you look at figures from France last year, February 20, to March 20, there was a 15-fold increase in the number of teleconsultations. Remember, we were sort of about beginning to learn about COVID-19 towards the middle end of March. But by that time, France and other European countries were already
Sorry to interrupt you, sir. Sir, your slide is visible in presenter mode to us also,
Okay.
sir. Yeah.
Okay.
If you are fine, then we are also fine with it.
No, let me use. Yeah, is that better?
Yes, sir.
Yeah, good, right. So because of the needs, we have to adapt. And so teleconsultations became so common. And so we look broadly at diabetes management in COVID-19 era. We all know that glucose levels could be affected in so many different ways. And apart from medical conditions, the fear, the anxiety, the tension, the irregular diet, the lack of exercise because of the lockdowns, all those can affect glucose management in COVID times, as well as, of course, the stress of the illness itself, the various inflammatory cytokines that we all talk about. And then on the other hand, the best medicine that we have today to control those inflammatory cytokines, the glucocorticoids, they also will cause worsening of glucose control. And finally, there is also a nagging sort of suspicion that SARS-CoV-2 may also damage the beta cells of the pancreas, and so could also cause or worsen hyperglycemia. And we all know that diabetes is a major risk factor for COVID-19 hospitalization, need for ventilation, and eventual mortality. And it's also related to the degree of glucose control. HbA1c is more than 7.5 versus HbA1c is less than 7.5. Clearly, there is a difference. And so diabetes control at the time of hospitalization is extremely important. And hence, our own government also recognized the importance of telehealth, which is, of course, much more broad-based beyond just diabetes consultation. Of course, medical care is part of it, but it can be used in a broader context of providing education, health information services, and various self-care via telecommunications. And so what about treating patients in the telehealth era, diabetes clinic adapting to new normal? We do have the legality of it. In the past, you were liable to be maybe sued if you were practicing teleconsultation, but the government of India, for one, woke up very early and in March 2020 itself published the telemedicine practice guidelines, and even the first consultation between a patient and doctor could be a teleconsultation. And clearly it has its advantages, as we shall see. Now, this teleconsultation or telemedicine applications could be a video consultation. You could use various apps for it, or you could use a WhatsApp video call. It could be a FaceTime, or it could be a Skype. It could just be an audio call as well. It could be text-based, it could be messaging, and it could well be asynchronous, that is by emails. Means you send a message and then the other party then sends back the reply, which is asynchronous, which is sometimes a little bit more difficult, but nonetheless could also be considered under telemedicine application. And in terms of telediabetology specifically, there are a whole host of advantages. For one, neither the patient nor the doctor is being exposed to the risks of infection. It saves travel time and cost for the patient. And in these times, healthcare professionals, there are so many occasions that you are exposed and then you need to isolate yourself. And then you are not kept idle. You can still continue to help your patients through teleconsultation. and there can be a broader access to healthcare system, and you could have patients joining you from all across the country, or even beyond the boundaries of this country. And I find there have been so many occasions where the son or the daughter joined maybe from Bangalore, maybe joined from UK, from US, from Canada, so as to assure their parents who are staying here in Kolkata. So those are clearly the reach of telemedicine. You can connect to anyone who has got this connectivity. And then there are different technology that you can make use of. The continuous glucose monitoring or the flash glucose monitoring, which can then be the data can be uploaded automatically to cloud-based software, so the physician at one end can read the data that has been collected several hundred kilometers away by the patient. So this is a great boon for all of us. At a teleconsultation, what are we supposed to do? Well, one is, of course, the general health education in relation to diabetes, general advice about COVID, and especially sick day guidelines and hypoglycemia awareness. Lifestyle advice is extremely important, especially about diet and exercise, because either because of the risk of infected people being all around you, so people do not dare to, or maybe sometimes use that as an excuse not to go out for any physical exercise, or because of the requirements of lockdown. Right now, our state is also under a almost 100%, not nearly so, significant lockdown till the end of this month. So that also precludes patients from going out and enjoying physical activity. But we do need to advise them even what they can do, even within their confines of the house, even maybe using the terrace, and so on and so forth. Muscle strengthening exercises, yoga, all could well be accommodated even in a limited space. And then in terms of drugs, we need to be careful. And overall, the general refrain is try not make major changes, multiple dose changes, multiple drugs being changed, adding several at a time. By and large, we try and make it more softly, especially in a telemedicine consultation. And then, of course, when we advise a drug like a sulfonylurea or insulin, we need to keep our patients aware of the risk of hypoglycemia, and all that requires advice on self-monitoring. Though I did say that I won't go into the nitty-gritties, I would just like to point out that most of the medications, in fact, all the medications that a patient with diabetes, a subject with diabetes was on and had good control before this, can well continue during this period, and even if one has got COVID and is being treated at home. Of course, one needs to monitor the glucoses much more frequently when you have COVID and are taking any of these medications. There has been a lot of discussion about the SGLT2 inhibitors in the past, and we were wary that maybe in the context of COVID, we should be avoiding it because of the risks of fluid loss and the risk of euglycemic ketoacidosis. However, at least we have the support of a clinical trial, the DARE study with dapagliflozin, which to my mind was really a daring study to try, which of course did not show significant advantage in terms of organ protection with dapagliflozin, but established at least its safety. In my mind, if I need to start someone in this COVID era on a telemedicine consult on an anti-diabetic agent, to me, DPP-4 inhibitors and metformin remain the safest bet with the least side effects. And even among the two, probably DPP-4 inhibitors are the easiest to start on. However, insulin, if someone is on insulin, clearly it should not be stopped. Monitoring should be more frequent, and glucose control should be assessed. This is about new cases. When we see a new patient, we have to document well, document all the names of medicines, generic names, dosages, time of intake, should all be clearly typed out, should be properly signed, and should have referral. And very importantly, quite often for the first time that the patient comes, patient has already seen a neurologist, maybe under treatment of a cardiologist, and so on and so forth. And we all have advised different medicines. We have to make sure that we are not overlapping. So maybe the patient is already on pregabalin, and maybe I am not aware of it. And then the patient complains of burning feet, and I add another duloxetine. So we need to make sure what the patient has already been taking, and then decide what next to add. In terms of follow-up, we need clearly to look at previous figures, previous body weight, previous blood pressure, previous HbA1c, look at the blood glucose monitoring chart. And so in this context, I would once again like to remind that patients need to have home monitoring devices, glucose monitoring, as well as preferably blood pressure monitoring. So, and they should be coming prepared for these teleconsults with the figures with them, so that we can advise and modulate and change our treatment as necessary. And we should also again advise what are the follow-up investigations to be done, and self-monitoring of glucose or blood pressure data should be discussed. However, there are so many challenges of this new technology that we have, by and large, been using fairly widely over the last year or so. I must admit that I started these consultations not very early on. Maybe I started from around May to June, so about a year now. So right now, of course, I have seen so many patients consulted over the, usually it's a video consultation. But we do remember there are so many challenges. Not all are tech savvy, especially the elderly. Web connectivity could be a big issue. Privacy concerns have been raised about the data that are being transferred. Even if the consultation can be done remotely, there are tests that need to be done. So the patient may have to go out, especially if you have an ECG to be done, an eye checkup to be done. For blood tests, many a time is a lab, people can come and collect blood from home. And then there has been, of course, at the beginning of the first wave, of the first lockdown, availability of medicines was an issue, but it's fortunately no longer an issue, at least the anti-diabetic medications. And then there would be medical reasons why we would need to have physical consultation. And then I must say that there are people who also do not want this remote consultation. There are people, old timers, not always actually old in age, but who like to have face-to-face meeting with the doctor. So there's also a social reason for physical consultation. And the challenges of telemedicine, we did highlight in our sort of overview of COVID-19 and type 1 diabetes. So type 1 diabetes itself is not a consultation, it's not a contraindication to teleconsultation. If you are seeing for the first time, I think it's best to see face-to-face, because there's so much of discussions to be done with the patient, with the family, especially the need to initiate insulin, to teach them self-monitoring, how to adjust doses, and so on and so forth. And if it's a new case, the first consultation for gestational diabetes, once again, it may be best to have a face-to-face consultation. Then, of course, if you have a severe foot infection, a gangrene, then it just can't be managed on a teleconsultation. If patient's having severe hypoglycemia, if patient is having any other severe infection that requires intravenous antibiotic, obviously the patient needs to be hospitalized most of the time. And then, of course, if you have an acute organ complication, myocardial infarction, and so on and so forth, then also patient needs face-to-face consultation or hospitalization. Dr. Anup Mishra did bring out a paper on his experience with a customized mobile van for screening, detection, and management of diabetes in urban underprivileged populations of Delhi. So that's another way to do it. If you can organize it, mobile van going to the doorsteps, or at least to the locality, and providing care. However, as we did say that there are situations where face-to-face consultations would be required, and in those instances, we have to make it safe for ourselves as also for the patients. So we have to screen the patients properly, their visitors, limit the number of visitors, stagger the appointments, ensure appropriate personal protection, maintain physical distance, ask patients to send relevant documents as far as possible electronically beforehand, clean frequently touched surfaces, and all of that. And over and above, get all of us vaccinated. That's extremely important, though we do know, despite 2 doses of vaccine, many of the healthcare professionals have got infected, and unfortunately, some have even succumbed to this infection. An issue that could be raised is about fees. Well, there could be different views on it, but in any case, the government has made it perfectly appropriate, acceptable, legal to charge fees for consultation. Some may even ask for a premium because the patient is not having to travel a distance, so you're saving on time and cost, but it's up to you. I have kept my teleconsultation fee the same as in face-to-face consultation. So there are several different ways, several different apps, several softwares that you could make use of in making teleconsultation more beneficial. However, not everyone would require or be comfortable with all. We can be aware of what is available and then choose what's best for you or your clinic. So finally, I'd like to wind up suggesting that good diabetes control, as Dr. Mittal has also mentioned, is very important. There are difficulties, even normal times, more so in COVID times, but telediabetology has come in a big way. Home monitoring devices are extremely important to help us go through this journey. We need to be doubly careful when consulting remotely. We need to know which patient we can treat remotely, which patient we would like to see physically, and then there's the scope of having something in between, having mobile clinics. There are new waves of innovation along with the new wave of the virus in area of digital health, smart data, and telemedicine. However, limitations still do exist with telemedicine, and there would be situations where face-to-face consultation would also be required. We are at the crossroads, sort of. We are adapting ourselves. Our patients are also adapting themselves to this new normal. Let's see where we go. Thank you very much once again for your kind sparing your time. I'll stop sharing.
Thank you, Dr. Shubhankar, sir.
Thank you, Shubhankar, for, as usual, a very crisp and precise presentation, and really putting the reality before us. And as most of you are aware, or most of you are practicing, we are also practicing a large amount of teleconsultation volume, which we have gradually gotten used to, despite hating it initially. But it enabled us to take care of many patients, especially those who are distantly located, and there's no question of travel. So our team has done about 6,500 video consults since this whole story started. These are not, we're not counting the ones that are always, endocrinologists are doing 24/7 phone consults, so that those are not counted. Anyway, so we really are running late. I'll just ask one question to Shubhankar. Lots of people want to ask questions, but I think one is important, and that's the one that's popped up first. So where do you place pioglitazone in this whole story? Dr. Durrani wants to know in treatment of diabetes in the COVID era.
Yeah, by and large, I feel if someone is well controlled with whatever medicines, I usually do not change unless there is a specific indication. So, so I would be quite okay. Of course, if the patient is hospitalized and has gotten heart failure, has got low ejection fraction, in all those situations, of course, we need to stop. But by and large, I feel it's okay. Overall, of course, pioglitazone has its own issues like weight gain, fluid retention, worsening of heart failure, and also from the bone health point of view, it's not one of the best. But as I said, that if someone is coming with a good control otherwise, I usually tend not to disturb the set of medications.
Well, with one last comment, then I will transfer the mic or the stage, whatever you call it these days. There's no stage, to the cardiologist. The last comment is that of late, Shubhankar, I have been bold enough to use SGLT2 after the DAPA study came out, not as a primary drug during severe COVID, but when people are recovering, going off, taking them off steroids, they were poorly controlled earlier. Now we need more OADs. In that context, I have become bolder and bolder with a fair degree of success. And I think only in the recovering months, really, I have not yet started them and someone was plunging headlong into COVID. That's not a great idea. So I think I will hand the stage or the podium to my cardiology colleagues who are, we're sorry, sir, we're a little bit late, but not really our fault. We started a little bit late. Thank you very much. We'll come back again.
So I think maybe
Dr. Dikshit can invite Dr. Ajit.
So thank you, Dr. Shubhankar and Dr. Amrish, for the wonderful diabetes symposia with the completely a new topic, that the diabetes management in the phygital way. So now moving forward for the CAD symposia, we have lined up with the 3 interesting sessions, and to start with the first session with our course director on the ACS in the young patient less than 45 years of the age, how to manage it. So for that, we have our course director, Dr. Ajit Mulasari, sir, and I would like to invite Dr. Ajit for the session. Over to you, Dr. Ajit.
So thank you. Can I allow me to share the screen? Okay, I hope you can see my slides.
Yes,
yeah,
sir.
we can see and hear you.
Okay. Now, the first question is, why am I talking about this problem at all? And what is so different when I call somebody as young myocardial infarction? And this is something we have to understand. And is the pathogenesis different? The clinical presentation different? Are their managements different? Are their outcomes different? And most importantly, do we need some secondary prevention which is different from myocardial infarction in the not so young patients with myocardial infarction? And I think all of these, in my opinion, are different. And this is very important for us to understand because the treatment and management of these patients are different. So the first question is definition. It was a bit vague, the definition, because we have multiple papers and multiple journals which classified the age for young myocardial infarction as maybe less than 45. Some people have said younger than 45. Some people have characterized it as below 40. There are even younger definitions of 30. But what we need to understand is that this is a very westernized concept of young myocardial infarction, which is not really applicable. Why? Because the patients whom we are talking about, who are characterized as young in the West, have one simple risk factor, and that is basically familial hyperlipidemia. And that is not usually the cause at all of our patients who are young with myocardial infarction. And this is something we need to know. For practical purposes, we have been treating these patients in all our cardiology clinics very, very often. These are people who are less than 45, and for the comfort level, that would be possibly the age where I would characterize patients as young. And these patients have a completely different way of presenting. Now, as I told you, the epidemiology from the West is somewhat sort of mixed. But UK, they say it's about 3% of the patients with coronary heart disease. The Framingham study showed about 12.9 out of 1,000 in men between 30 to 34 years, and women about 5.2 by 1,000. But I think in general, it used to vary between 4 to 10%. So it's about, say, about 5% to 10% was the worst in the Western literature, which we went about looking at. Now, the pathogenesis, the second point after definition could be atheromatous coronary artery disease, but there is also the non-atheromatous coronary artery disease, and also something which I'd like to talk about is the hypercoagulable states. And this could be either in isolation or mixture. And patients present very often with a mixture possibly of these problems when they're in the younger state. Now, atheromatous coronary artery disease, which presents in the young or the less than 45, in India, the commonest cause is cigarette smoking. Apart from that, you may have positive family history, and I touched that, how we can identify that. Lipid abnormalities are rare. It is common in the West. If you have a patient who's young, who presents with MI, he almost is always tested for a lipid abnormality, but that's not true for a South Asian population. Overt diabetes, yes, it can be in young patients, but not in the severity what you expect patients to have. And I'll show you some data on that. Obesity, the classical risk factors are all there. Social stress is a big cause, in my opinion. And then you have non-atheromatous coronary artery disease, which are relatively rare. That's the coronary artery anomalies, the myocardial bridges, the peripartum spontaneous coronary artery dissections, embolizations from vegetations, coronary artery aneurysms, tumor and paradoxical embolism, and in the West, and now coming into India, unfortunately, is drug abuse. So these can, with normal coronary arteries, can create a problem. When I mean epicardially, they could be normal and they could create a problem. And the third most important thing, which is, I think, the most important thing, which is additive in many of the young MIs in our country, is a hypercoagulable state. And these are not the classical hypercoagulable states, which are called as the antiphospholipid, the lupus or the nephrotic syndrome, or the factor V bleed or contraceptive pill, but it's more related to lipoprotein A, which could be possibly one of the triggers which worsens problems in these patients with myocardial infarction. Now, the next question is, since we have talked about the pathology, is the clinical presentation different? Young myocardial infarctions don't come with progressive angina. They usually come with a fully evolved MI as the first presentation. If you go back to their history, you may pick a duration of symptoms, which is less than a week usually. The diagnostic criteria is the same in terms of ST elevation, the T wave upright, and the Q waves exactly like the older patients. We don't have a separate diagnostic tool. It's the same issues. But abnormal Q waves are usually seen in patients who present later than 12 hours of the onset. We can also have some atypical presentations of non-specific T waves, ST depressions, T wave inversion. And I think, as in adult patients and other not young MIs, cardiac troponin is a very important marker. But remember, when young people come with some ECG changes and chest pain, be careful that you don't miss myopericarditis and pulmonary embolism. These two are common mistakes that you make in the ICU or in the emergency room. Remember, evidence of drug abuse. I had two patients about 2 months ago, both in the 30s, who came one after the other with an acute myocardial infarction. I was a little struck that the first patient came in at 30 and we did a primary PCI and we didn't have time to discuss what was the trigger. And in the next few hours, another patient came in who was 32 years. And by the time I finished the primary and came down the two patients, and I was speaking, I saw the two relatives of the patient speaking to other, and I was pretty surprised that they would knew each other. And that's when we went through the history, and then came that both these boys were in a rave party and they got into a myocardial infarction. So I think that these things are not uncommon in India now, and you need to be going after their presentation and history a little more detailed. Dyslipidemia is not so common in Indian patients with myocardial infarction. This is a JAMA paper which we published of a system of care for ST elevation myocardial infarction in Tamil Nadu. And the interesting thing was 2,400 plus STEMI patients were looked at in a period of pre versus post intervention. And we saw that putting a system of care with a hub and spoke model with ambulance helped in reducing the 1-year mortality significantly by about an absolute 3.4%. This showed 2 or 3 other things which was important. Apart from the issue of the system of care, it also showed in those 2,420 patients, there were 591 patients who were less than 45 years of age. That is an absolute percentage of 24.4%. So it's no more 4%, it's no more 10%, it's close to 24% in Tamil Nadu. So the next issue was if you looked at women and men, you can see in female population, clearly what you can see here is that if you're less than 45, the female population is lower. So it's a male-dominated disease in the less than 45 as compared when it goes up a little bit more in women when you're above 45. Diabetes, we would think that is very common, but it is more common when you're more than 45 than you're less than 45. Hypertension is also more common when you're elder or more than 45 than less than 45. Dyslipidemia in both groups is very low. Smoking is extremely common, and in men is the single most important risk factor in the less than 45 years of age. So what I'm trying to say is there's a male preponderance in the less than 45. The traditional risk factors like diabetes, hypertension are not so common in the younger patients, and at least in the males, smoking is the single most important risk factor for these patients. What is the age? The mean age is approximately 40 in both women and men in the young myocardial infarction. As I told you, if a lady presents with young myocardial infarction, you should look for diabetes a little more carefully because obviously the female hormones protect from CAD and diabetes upsets that algorithm. Again, the same thing for hypertension. It's much more commoner if a woman presents with young MI. Again, dyslipidemia is no, and what you can see with smoking is extremely common in young MI as compared to in women in India. Now, what about the process measures between patients with less than 45? Do the patients present earlier? You can see clearly, yes, from symptom to onset of the first medical contact, it's more or less the same. The toe to balloon times are almost the same, but the total ischemic time, that means the time from the pain to the procedure is a bit faster in the young patients. And maybe because they come with straight an MI, they get a bit of, get earlier treatment and they come earlier to the hospital in terms of treatment and then get treated more quicker because they are in the younger population group. The time to fibrinolysis was no different. The other process measures were no different, and I'm not going to waste my time in this. But what is very important is some of the other characteristics. If you're less than 45, you're likely to have single vessel disease. That's only one vessel disease. If you're more than 45, you're going to have two vessel or multi-vessel disease. Your LAD is the commonest left anterior descending artery, which is the main artery, is more likely to be the primary diseased artery if you're less than 45. And the other arteries are more often seen in the over 45. So what it means is single vessel disease with LAD involvement is more common in the young myocardial infarction patients. Also interesting is that the thrombus burden is high, and hence the TIMI flow, which means that the perfusion level to the epic myocardium is much, much higher when you have the patients who are presenting in this whole thing. So we have to be very careful in these patients when we treat them for myocardial infarction. The mortality of the patients who are less than 45 as compared to more than 45 was lower in the patients who were less than 45 as compared to more than 45 at all times, one at the hospital, 1 month and 1 year. That would simply mean because they are younger, two, they have less diabetes and hypertension and other risk factors, and clearly they take treatment a little bit quicker. Many of the other complications are more or less the same, but shock is again more common in the older MI because again, they have multiple risk factors, and other like minor strokes and stuff like that are most commoner in the older people. So clearly what it means is that the outcomes are poorer in the elder patients who are more than 45 and are relatively better in the less than 45 patients. Now, if you look at the 45 and less, men versus women, what is interesting is that if you look at, I'm sorry, the slide, it doesn't mean more than 45, it is less than 45 in women. And you can see clearly the women do badly as compared to the men. And that is expected because as such, women access care slower overall. They get treatment less often. And unfortunately, if you're young, then your risk factor profile of diabetes, hyperlipemia, and hypothyroidism is much higher. And therefore, there are multiple risks predisposed to more mortality in hospital 1 month and 1 year. The rest of the hospital measures are known. This paper we just published in Heart, Lung, and Circulation just last week. It was an important paper which showed why we have this problem in the young as compared to the old. Now, I want to show you some examples of cases and explain the pathophysiology and biology of these patients who present. This is a typical guy, 32-year-old IT professional, stressed in his work, smoking, hypertensive, not taking medications properly. The body mass index is higher, no chest pain, 1 hour of chest pain duration, presented to our ED, and ECG showed an anterior wall MI. So that's the ECG. Very clearly, you can see the ST is up, very quickly presented to the ER and to the CCU. And you can see typically, and you can see this is the angiogram, and you can see this the left angiogram, and you can see the LAD, which is blocked here. So what do I do normally? I just put a balloon and try to open it up with a balloon here. And then what happens is we take a picture and you can see the amount of clot. This is full of thrombus here. If you try to stent these patients at this point of time, all this clot will go down and block the distal vessel and get you into trouble. So you need to hold your stent back and treat these patients medically. So what we do is once the pain comes down and the 0-hour ECG is down, we just keep them on usually 2B3A receptor blockers, antiplatelets to calm down the artery. And we bring the patient up for the next day for an angiogram to check how it looks. Has the thrombus got better? The thrombus looks better, but you can see here that there is still some stuff ready. So the next decision is, do we need to do anything? No, because the TIMI flows are good. Don't interfere with that vessel. And this is a completely different paradigm of treating these patients. You're not putting a stent at all in these patients. And when you look at them 1 month later with an angiogram, you simply see the whole pathophysiology is different. And the pathophysiology shows simply is that the arteries are more or less, yes, there is some mild blocking, but you can't, it's like a stented vessel. There is nothing needed to be done for these patients. You can just treat these patients medically. And what do I do for these patients? I look at their pathology by a test which is called an optical coherence tomography. And for obviously, I'll just explain to you what you can see here is there is minor atheroma. All this yellow stuff is minor atheroma, but there is no plaque rupture, which is a classical pathology or disrupted coronary intima is not seen in these patients very often. There's something called as plaque erosions, and they are basically high lipid content plaques without a rupture. In many of these patients, you will see that just good medical therapy is all that you need. This patient just got anticoagulants and aspirin because there was a lot of clot. We used a single antiplatelet on the long term and had no stent for this patient and continued to do well. So the difference of pathology is a plaque erosion, not a rupture, no much obstruction with lipid plaque, but it's basically thrombus, which forms on top of an eroded vessel. And that possibly is due to a hypercoagulable state created by smoking, maybe homocysteine levels and lipoprotein A, which triggers this problem. Similar second patients, 32-year-old smoker, same pain, evolved anterior wall MI, presenting to you with LV dysfunction, and the same story. And you can see here that in the angiogram, you can see stuff here. And you can see again, full of thrombus. This is very, very bad thrombus. But the problem here is this thrombus is almost limiting the vessel and it is almost blocking the vessel. So we can't leave it alone because the thrombus will. So we do some multiple sections and then we fix a stent and be sure that the flows are good on these patients. So you may have a lot of thrombus, but if your flows are not good, you may still have to stent these patients. So what I'm trying to say is that the presence of myocardial infarction in younger patients is not small. The classic examples of what we say of cocaine abuse and stuff like that is less common in India, but we have to keep a watch on other issues. We have to look at unusual causes of spasm and atypical causes like SCAD or in women. The treatment is exactly the same, that to take the patients to the cath lab, but the difference is once you see that the artery has not got a block which is severe, which you can do with imaging, then you just fix it with medical treatment. And in fact, there is now data that if you put a stent in these patients, you're unnecessarily creating stent problems in the future in young people, and that may not be a good idea. So I think the younger patients should be early perfused, they should have primary PCI, they respond very well to lysis because the clot is the problem, and they can have it either peripherally or tenecteplase. We don't have difference between data between these two groups in terms of neurolytics. I use a lot of intracoronary lytics, thrombosuction. I try to avoid stents if feasible, but what we do is younger patients do well. We need to use aspirin and clopidogrel. If there is a lot of clot, I use warfarin on these patients. We use high statins because again, they have a lot of lipid content in the eroded plaques. And the other treatment is exactly the same. The most important change I would suggest is lifestyle change of stopping smoking and losing weight, good control of diabetes and lipid abnormalities, which is important. So this is a paper I just published in the Journal of American College of Cardiology. And this is regarding the patients of Indian origin, South Asians all over the world. And they have a polygenic risk score, which you're born with, which predisposes them to an absolute risk of heart disease 1.6 to 1.7 times more than patients of Caucasian origin and or Southeast Asian population. This is pan-world in the US, UK, India, Bangladesh, Pakistan, Indian settled in the US, Indian settled in the UK. And this is something which we can predict by polygenic risk scoring. So everything is not about lifestyle and other things. There is a genetic predisposition, and we can predict this by a one-time blood test in patients who have presentations which are early. So conclusions, I think that what I would like to say, 24% of our patients are young. Smoking is the main risk factor in men. Diabetes and hypertension is uncommon. Better prognosis and lifestyle change with smoking off is important. I think plaque erosion is the commonest pathophysiology, more than plaque rupture, with the prothrombotic milieu which presents in these patients. And genetic analysis of single nucleotide polymorphism in specific genes and intravascular imaging may provide an insight to the pathogenesis and treatment. Thank you very much.
Thank you. Thank you, Dr. Ajit, for the wonderful session on the young MI. We'll take the question and answer session at the end of the CAD symposia. And I would request all the attending clinician, if you have any question, you can write it on the comment box, which is on the right side of your screen. Now, I would request Dr. Ajit to introduce our next speaker.
Yeah, I think Dr. Tiny Nair is one of the most prolific speakers and a good friend of mine, and we have shared many a podium. I really respect his knowledge. He's from the PRS Hospital in Trivandrum, a very, very good speaker, well-read, and I think there's publications and his oratory skills all over the country is very, very popular. And I'm sure Tiny is going to give us a very, very nice presentation on stable coronary artery disease. Over to you, Tiny.
Thank you, Ajit, for that nice introduction. Give me a moment by the time I share the screen. Is my screen visible and am I audible?
Yes, Danny, no problem. Please
Thank
go.
you. Thank you. So we will be talking about what is new in chronic stable angina. We'll just talk about what is new, because chronic stable angina, what today we known as chronic coronary syndrome, is known to us. And in the next session, Dr. Rajiv would talk about the way we can deal with the residual risk. So I would kind of not touch upon the treatment aspects. My involvement in chronic coronary artery disease dates back to about 3.5 years back, with the ESC working group on coronary pathophysiology and microcirculation invited me to be a part of their group, and I was fortunate that I was representing this part of India. And the meeting at that point of time, this was much pre-COVID, that was by 2019, before the new guidelines came in. The meeting was in Hotel Hilton in Vienna, Danube. I still remember that all of us reached at night, and by the time we reached, it was already past sundown. And when we looked out of the hotel window, it was all like, kind of foggy, and we could see nothing. By the time we woke up next morning, it was totally different. We saw the beautiful Danube there, flowing just by the hotel, and just on the opposite side, the city of Vienna, and it was very nice. But the whole atmosphere changed the moment we entered the hall, and we saw that the amount of confusion while creating those guidelines were tremendous. And this would be a little bit of glimpse of what at least I learned and took home from that meeting and subsequent learning in 2021. We all know that the coronary artery depicted in the cartoon there gets atherosclerotic plaque. It thickens, and as you saw beautiful OCT pictures that Dr. Ajit has shown you, that obstructs the coronary lumen. And as there is obstruction in the bottom image, nothing really happens till it's about 70–80%. The person is asymptomatic. Once that block is significant, if we put the patient on, let's say, a treadmill exercise test, we see that the ECG shows features of myocardial ischemia. And at that point of time, because sufficient blood is not going into the myocardium, people tend to get symptoms of chest discomfort, the classical effort angina. So that blocked coronary artery, in our mind, we classically translate it that once it is severe, we have myocardial ischemia, whatever way we look into, whether by a stress EKG or stress echo or perfusion scan. And that is correlating with the symptoms of effort angina for the patient. And also we logically deduce that over time, that plaque, as you have seen in those OCTs, will become rupture prone, unstable. And once they have a surface erosion or a true plaque rupture, the patient ends up in an acute coronary syndrome. So in our mind, the natural history of atherosclerotic plaque is a plaque asymptomatic, becomes symptomatic, ischemia, angina, and an event like an acute coronary syndrome. But the problem is there is a lot of trouble in between, and they are, for example, we have on one side the atherosclerotic occlusion, we have the myocardial ischemia, we have symptoms of angina. So they are different. One is the ischemia, as we see in an EKG or an echo or an perfusion scan, but symptoms are different. Patient may have symptoms or no symptoms, and finally a cardiovascular event. So let us see one by one how complex the relations are. Not that we know the answer to everything, but let us look at the relation. But to know the relation, we have to spend 2 complicated slides on the coronary pathophysiology. Stay with us, because this is little complex, but we translate that into clinical science as we proceed. First thing is that what we see in an angiogram, the coronary artery, is only a small part of the whole thing. We know that it's a conduit, as you can see there, through which the flow takes place. But we also have a large part which is hidden. That is what you see now in the picture. The initial part is where the arteries are between 100 microns and 400 microns, where it is just like a pressure reducing area. So this narrowing reduces the perfusion pressure to the myocardium. The next part, which is between around 100 microns, between 10 and 100 microns, are the narrower part of arteries, which are under tremendous metabolic control. They respond to acetylcholine, they respond to adenosine, they respond to nitric oxide, and that are the areas which are tremendously under metabolic control. Okay, and finally you have the capillaries, the part where the oxygen is exchanged and sent into the myocardium. Now, for practical purpose, we see only the macro circulation angiogram, and we see some kind of TIMI flow into the TIMI blush into the myocardium, but that entire area, that pressure sensing, pressure reducing area, the metabolic sensing area, and the exchange are together micro circulation. And in our mind, we have very little knowledge or interest in looking at the microcirculation in chronic coronary syndrome. Now let us take it one step forward. If we look at that cartoon, then we see the proximal artery and the distal part are the branches of the artery. They're small branches of the artery, right? And these arteries are part of the microcirculation. Now let us say that this is a normal person, he does exercise. And as he exercises, look at the smaller arteries, they dilate, right? So the smaller arteries dilate. Why? Because the myocardium needs more blood. So the smaller arteries dilate during exercise and blood flow increase. That's normal physiology. Now consider that this patient has a blockage in the coronary artery. And if you can see there, so the proximal pressure before the blockage is normal. Let's say perfusion pressure, pressure of 100 millimeters mercury. And because of the plaque and block there, the pressure below is 70 millimeters mercury, which means the pressure difference between 100 and 70 is that 30 millimeters of mercury. And this patient, when he's sitting quiet, may not have a symptoms of angina. Now let us presume this person does a little bit of exercise. Okay, what happens then? His microcirculation, this area beyond the block, dilates in an endeavor to increase blood circulation to the myocardium, just like the normal person. And so what happens is that the normal pressure, proximal 100 remains same, but the distal pressure drops because of vasodilatation. So that 70 in the left picture now comes down to 40. So the gradient is now essentially 60 millimeters. So when a person with a coronary artery disease exercises, we see that the gradient increase. Okay, so if we look into a graph, the top graph is normal, top line, which is a healthy person. So the coronary flow increase, but unhealthy blocked person, the coronary flow does not increase and the gradient increase. Now, unlike a large artery, this is a very small artery, like they're 3 to 4 millimeters in dimension. So you can't really put a catheter and measure the gradient. How can you measure the gradient? But instead, you can put a Doppler flow wire, and instead of the pressure drop, you can calculate velocity. Because as the gradient, the narrowing increase, the flow velocity increase. And that is what in short form, we call it as fractional flow reserve or FFR. So all this slide conveys is that FFR is the functional component of the block. How severe by the pressure difference. And the plaque that we see in angiogram is the degree of plaque that we see in an image. So anatomic image shows us the plaque and the physiology of that plaque. The pressure difference is shown by a test called FFR in the cath lab, fractional flow reserve. Now, so if we have that epicardial artery in the diagram and we have that block there, FFR shows us the physiology of the block, the functional severity of the block, right? Now, if we look into the microcirculation after the epicardial artery, that is shown by what we call as IMR, or index of microvascular resistance. So index of microvascular resistance shows us the microvascular level resistance. So they're different. Understand that. So the epicardial resistance is FFR, the microvascular resistance is IMR. And if you look into the entire resistance together, it is called a CFR, or coronary flow reserve. So the entire thing is coronary flow reserve. The microvasculature resistance is IMR, or index of microvascular resistance. And the FFR is fractional flow reserve, which is the functional narrowing of the epicardial artery. Okay, now let us look into the FAME trial that came in 2010 that tried to look into something very interesting. Okay, they tried to correlate between the anatomic block that we see in the angiogram, 80% block, 90% block, 30% block, to the functional block that we see by FFR, right? And look at the relationship, very interesting. Which means here in the x-axis, we have stenosis as 50 to 70, 90, 90 to 99. And in the y-axis, we have the FFR, the functional narrowing. So y-axis functional, x-axis anatomic stenosis. Now look at that. If we draw a line of 0.8, above that functional is normal, below that it is abnormal. If you take people who have a narrowing between 91 and 99%, you see just about 4% of people have functionally no significant block, 4%, right? So anatomically, you see 90% block, there are about 4% people who may still not have a functional block. But when you look at anatomic narrowing between 70 and 90, that number of people who has no significant block by FFR or functional imaging goes to 20%. And when you are looking at something like 50 to 70, you remember Dr. Ajit showed you an angiogram where post thrombosuction, there was hardly any block, 50 to 70. They are likely that about 65% of them will have no functional blockage at all. So anatomic block and functional block by FFR don't necessarily correlate, especially when we are talking about blocks between 50 and 90, right? So what they did was they tried to look into those who were diagnosed as triple vessel disease, 3 vessel disease, 115 of them, 3 vessel disease, and put them for an FFR or a functional imaging. And what did they find? They found that functionally, it became 2 vessel disease in 43%, single vessel disease in 35%, no vessel disease in 9%, and continued to have 3 vessel disease in about 14%. So what are we talking about? Which means anatomy and physiology don't always correlate. Right. Now, this is a 55-year-old female who came to us with a classical class 2 effort angina. We put her on a treadmill exercise test and see on 7 METs she has significant ST depression in lateral precordial lead. So we said treadmill positive. You have an angiogram done, recovery normal, angiogram done, and look at that angiogram. Normal coronaries. We know that females quite often we see this picture that the coronary angiograms are normal despite having abnormal effort intolerance and ischemia. So anatomically no block, but there is ischemia. So what are we talking about? Coronary occlusion did not necessarily correlate with myocardial ischemia. So ischemia and occlusion in coronary may not correlate, right? That is point number 1. Point number 2, this is a database from looking at women that came in JACC, looking at women with chest pain. And women with chest pain, they did an angiogram and classified them into non-obstructive, 1 vessel disease, 2 vessel disease, and 3 vessel disease, right? And then they looked into their symptoms. How many of them had typical angina? You see whether they had blue, non-obstructed artery, or red, 1 vessel disease, or gray, 2 vessel disease, or mauve, 3 vessel disease. The symptoms were typical angina about 30-40%. Didn't differ. Okay, they said it might be atypical discomfort. They looked into the functional disability. Same. Non-obstructive 50%, 1 vessel disease went up to 70, 2 vessel disease went up to what? About 50, 55, and 3 vessel again to 70. So it didn't match. So what are we talking about? Okay, we are talking about, we already know coronary occlusion and myocardial ischemia does not match. Now we see coronary occlusion and angina also doesn't match. You can have occlusion and no angina, and you can have no occlusion and angina, right? They don't match. The third interesting point is prognosis, right? If you look at the angina prognosis in the Clarify registry, you have angina on one side and they compared it with ischemia. So you have symptoms of angina and you have inducible ischemia. So how do they dictate a prognosis? Look at that. If you look at cardiovascular death, non-fatal MI, ischemia is right at that straight line, but angina, significant worsens prognosis, right? Look at MI, angina, ischemia on straight line. Again, angina, increased outcome. Which means looks like angina, presence of symptomatic angina is a far more worse prognostic sign than even demonstrable ischemia. But think about it, we always go by whether the treadmill shows an ST depression. The person walks on treadmill and says, doctor, still I have a heaviness, and his treadmill does not show an STD change. We say it's all, he is all psychological, give him some amitriptyline or alprazolam and send him home, right? He might be having a true angina and his treadmill may not show an EKG change. Okay, right. And if we look into the clarified registry further and look at the 7,000 patients of angina and divide them who had persistence of angina and resolution of angina, 3,600 at persistence of angina, 2,800 at resolution of angina, we see there is significant difference between their CV death and MI, 7.6 and 5.9, and the hazard ratio is totally different. So persistence of angina is important. You know, despite the fact that once we know that they have an atherosclerotic vascular disease, we treat with statins and maybe antiplatelets and vascular protective drugs. Both these groups receive them, but still resolution of angina gave a better outcome, right? And they were difficult to explain. So what did we learn? Angina is more prognostic than ischemia. So that question brings in, suppose a person has both angina and ischemia. What does it mean? Yes, it shows that if we look into the hazard ratio of adverse cardiovascular events, this came in Archives in Internal Medicine 2008, we see that presence of angina and ischemia together has the worst outcome. So yes, when a patient of angina also has inducible ischemia, he has the worst outcome. So you might say, okay, it's all confusing. So ischemia plus angina is the worst, but angina is more prognostic than ischemia. And coronary occlusion does not necessarily translate to angina, or coronary occlusion does not translate to myocardial ischemia, and vice versa. The third interesting thing about angina that we often don't understand is there's a lady with a class 3 effort angina. We did a coronary angiogram and it was normal. So what is it? Today we call them INOCA, or ischemia with normal coronary angiogram. Ischemia with normal coronary angiogram, INOCA, is seen in about 40 to 50% of women. We today know that they are not normal, right? If we look at the obstructive atherosclerotic disease in men, for example, the classical ischemic heart disease, we know that if we look at the angiogram, there is a focal atherosclerotic plaque, right? And that is why if we look at the pressure drop inside the coronary, there's an area when suddenly the pressure drops. So it's clear pressure drops there and there is significant plaque there. So dilate it and the disease would go. But in a female, when we talk about INOCA, they are not normal. They have diffuse atherosclerosis. So the graph shows gradual lowering of pressure. So we should not think because the angiogram looks normal, they are all normal. Some of them might be normal, but they might have diffuse atherosclerosis. And that might actually dictate their prognosis. So they might also need statins and good secondary prevention prophylaxis to prevent an event rate. When we see an angina with normal coronary angiogram, we talk about epicardial. We know that the epicardial coronary artery is fine. So there are just two possibilities. One, there may be vasospasm. The angiogram looks normal. There may be vasospasm and the person gets angina. Or there may be disease of the microvasculature. Okay, microvasculature also can get spasm, but we are not going into such complex stuff. So there are a lot of good papers. This slide is put so that if a resident is watching, they can read this article. They're fantastic. This is from Italy. Filippo Crea talked about 3 years back, wrote about coronary microvascular dysfunction and update. And this is by Viviane Tacquiti, who wrote about, she's from Brigham and Women's Hospital, wrote about coronary microvascular disease. And the most interesting article is atherosclerosis, stenosis, and ischemia, one primary, one secondary, one tertiary. Very interesting article, jointly written by James Min from Presbyterian Hospital at New York, and Dr. Chandrasekhar, who is the associate editor of JACC from Minnesota. Now, these basically, okay, we are looking at vasospastic angina. We know that we have diagnostic criteria in the cath lab, acetylcholine provocation, pain, ECG change, and more than 90% vasoconstriction of the artery in the cath lab shows us there is vasospastic angina, but we don't really often do them, right? But what about the long-term prognosis? You know, many often we say, okay, if you get sometimes once in a while pain, it may not be nothing. and vasospastic angina is good. But in a large cohort of study, 10-year registry data, 1,700 patients of vasospastic angina showed that the incidence is 3 per 100,000 population. And what is more interesting is that the data shows that if you see cumulative mortality, we are not talking about events, mortality in percent and follow-up days of 3 years, you see there's a 15% mortality, 15% mortality at the end of 3 years, which means vasospastic angina is not benign. So how do we diagnose vasospastic angina? When I see a patient, if there's a variable threshold angina, which means patient says, doctor, some days I can walk to my office without any problem. Some days I walk about 10 feet, I get a classical chest discomfort, I stop, and then, okay, it goes away. Okay, preserved effort tolerance. You put him on a treadmill. Treadmill is negative. And that particular day, he walks all 4 stages. There is no angina, no ischemia, right? ST elevation during exercise. If there is an ST elevation during exercise, it might indicate, like the classical prinzmetal angina, he might be having exercise-induced coronary vasospasm. And of course, syncope during exercise, because sometimes there might be sustained arrhythmias during exercise with syncope. And with that background, you do an angiogram. You find the angiogram normal. Don't send him home telling that, no, you have no disease, but he probably has variable threshold vasospastic angina. Now, that brings us to the more complex problem of microcirculation. So from the angiographic large artery on the left, let's look at the microcirculation. Now, microcirculation, if you draw a diagram, that is normal. What can happen is there may be increased resting tone. There are some people whose resting tone is increased, for example, left ventricular hypertrophy. So if they have a resting tone which is high, as we exercise normally, the microcirculation we showed in the first slide should dilate. If it doesn't dilate, increased resting tone, we can have angina. Second, we can have decreased dilatory capacity. Okay. Third, we can have coronary vasospasm of the microcirculation. And fourth, there might be microembolism. Okay, now what clinical scenario can I suspect it? Smoking and pheochromocytoma can give rise to increased resting tone of the microcirculation. Decreased dilatory capacity happens in left ventricular hypertrophy and obesity. Coronary spasm, you just now saw Dr. Ajit showing you a slide of cocaine. And of course, in Takotsubo, there might be spasm of microcirculation. And microembolism, COVID, post-COVID angina can be a result of microcirculatory embolism. So, increased resting tone, smoking pheochromocytoma, decreased dietary capacity, LVH and obesity, spasm, cocaine and Takotsubo, and microembolism, COVID. Now, microcirculatory dysfunction has been very clearly graded by the ESC. For example, if you have type 1, means your myocardium is normal, your coronary artery is normal. So normal coronary artery, normal myocardium, there's no disease, and still there is a microcirculatory disease, is type 1. Type 2 is more easy to understand, where there is myocardial disease. Either the myocardium is hypertrophy, hypertrophic cardiomyopathy, dilated cardiomyopathy, Anderson-Fabry's disease, amyloid, myocarditis, aortic stenosis, LVH. So because of deposition of stuff in the myocardium, the microcirculation does not dilate. Okay, type 2. Type 3 is obstructive coronary disease associated with microcirculatory disease. So patient already has stable angina or acute coronary syndrome, also has microcirculatory disease. Important, because you go ahead and dilate the coronary, do an PCI, you say, oh, your angiogram is now normal. Patient comes back and says, doctor, I'm not feeling better. I still have angina, microcirculatory disease, type 3. Then type 4 is iatrogenic, where post-PCI or post-CABG, because of our guide wire or our drugs have damaged the microcirculation. Now, microvascular disease is peculiar that 40% people with angina as non-obstructive disease are there. You need to suspect microcirculatory disease. They're huge in number. 4 million people in US is supposed to have ischemia without obstructive CAD. Can calculate IMR and CFR. Now they're on a single catheter, single Doppler wire. You can do an IFR and get all the data of microcirculatory problem. They are not low risk, and they can have sudden cardiac death. And of course, they can have new onset heart failure angiogram is normal, epicardial coronary normal, they can have new onset heart failure because of microvascular. So finally, what is the clinical clue to microvascular disease? I'm practicing medicine, right? What is the clue? This is the as we end the talk, we should take this so much. How should we think of a clinical clue to microvascular disease? Number one, variable threshold angina. So when a person says I have a variable threshold angina, it can be either coronary vasospasm or a microvascular disease if the coronary angiogram is normal. Second, low heart rate triggers like mental stress. Microvascular angina tends to be triggered by low heart rate triggers like mental stress. So if a person says that when I am angry or when I'm emotionally upset, I get angina, but I don't get it when I walk for 3 kilometers, think of microcirculatory disease. It lasts for several minutes after cessation of physical activity. The usual classical epicardial disease angina subsides the moment the person takes rest. Climbs stairs, he gets angina. The moment he stops, in a few minutes it goes away. If it lasts longer, think of microcirculatory disease. Poor response to sublingual nitrate because sublingual nitrate doesn't dilate microcirculation well. And of course, stress test positive, but stress test with sublingual nitrate, not better, right? And finally, stress echo. If you do an adenosine dipeptidyl stress echo, there may be angina and ST change, but less of regional wall motion abnormality. So dichotomy between an echo regional wall motion abnormality and angina and STD change gives a clue it might be microvascular disease with, of course, a normal epicardial coronary artery. So I repeat, important points: low heart rate trigger, variable threshold, angina lasts after cessation of physical activity, poor response to sublingual nitrate, and of course, ST change in angina, but less of RWMA by stress echo. So in conclusion, chronic coronary syndromes is a complex disease. So we still fail to understand the complex relationship between atherosclerotic plaque, inducible ischemia, and symptomatic angina. They are complex. They are complex. 40 to 50% of patients can have angina with non-obstructive coronaries. There you need to think about one, vasospastic angina, and second, microvascular angina. They are entities which needs treatment, and they need not be thrown away telling that they are psychological and they have no coronary artery disease. If CAG is normal, angiogram is normal, think of vasospastic angina and microvascular angina. Both are, as you can see there, underlined, because we see often these diseases are missed and wrongly diagnosed. So the take-home point would be that, for example, in Zoom, we see the image, right? But don't always go happy with the image. Today, during COVID, we are all dressed up fine on top, but we don't know what exists below. If you see, it is different. So the point is that imaging may be deceptive. Imaging may be deceptive. Think outside the cath lab, think of vasospastic angina and microvascular angina when you see a case of chronic coronary artery disease. Thank you for your time and attention, and I give back the podium to Dr. Ajit.
Thank you, Tiny. And we'll go on quickly to the next session because we have an overseas speaker after Dr. Rajiv Agarwala. So can we just put on Rajiv's, his introduction? I think Rajiv again needs no introduction. He's one of the wonderful speakers, and he has spearheaded a lot of the programs of prevention in India. And I've heard him at multiple talks, and I'm sure he'll give a wonderful talk on residual risk. So Rajiv, I don't want to introduce himself in detail because I think
Sure. Please show me the slide. Show me the slide.
Rajiv, slides, please.
Yes. I think I'm both visible and audible.
Yes, please.
Okay. Thank you, Dr. Mulasri. And I'll carry the torch forward where it was left by the two previous speakers. And this discussion is more of an overview because it takes a lot of time. There are almost 5 talks which I have tried to compress in one talk, and I'll look after my time limits. And I'll begin by showing one slide that coronary PCI or angioplasty is not like artery cleaning, is beyond it. And I keep on insisting that as we grow older, wiser, gray in hair, we start understanding that coronary artery disease is beyond angioplasty. And let me show you the commandments I wrote. Atherosclerosis never sleeps. It's a disease of the vessel wall, not of the lumen. It's a metabolic disease. The mechanical treatment just resets the clock. So you should carry these three fundamentals, foundation, in subsequent discussions in your mind. Since these strategies, they increase the burden of pill and cost, it is common sense that if we profile the risk of our patient, the risk-benefit ratio or cost-benefit ratio will increase in higher risk patient. But these strategies equally apply to the whole spectrum of coronary artery disease patients. And this is Tom Lucier in ESC, one of the journals of European Society of Cardiology, and talked about residual cholesterol risk, residual inflammatory risk, thrombotic risk, triglyceride risk, LPA risk, and diabetes risk. So let me touch some of the recent advances, what has happened in these domains. We have newer strategies of development for the development of lipid lowering therapies. We know over a period of time, beyond doubt, that lower is better. We have come down to the bottom of 30/40 milligram per deciliter of cholesterol LDL in patients who have high risk coronary artery disease. And this is a very interesting graph. If after maximum statin dose, your LDL is around 100 and you reduce it down, you have mortality benefit, total mortality benefit that had been shown by Odyssey outcome trials. If you are moving from less than 100 down to bottom, you have event reduction, no mortality reduction. So under giving an understanding that baseline residual LDL is one of the very important determinants of the outcome of aggressive lipid lowering. This is one slide which I have recently acquired, shows that within 6 weeks, a patient was subjected to what is called a near infrared spectroscopy, published in European Heart Journal by Japanese worker. You can imagine that high intensity statin, how much the lipid content of the plaque has been reduced. So it is a reality, it is not fantasy. What are the new therapies? What are the new therapies which have come on the horizon? They are Orion series of trial, which takes into account the inclisiran, which work on messenger RNA silencing. There is no time to explain you exactly where it works, but it is proximal to the PCSK antibody sites. Then we have bempedoic acid again, which works proximal to HMG coenzyme reductase inhibitors. And we don't have an outcome data with bempedoic acid, but combined with ezetimibe or with statins, it works wonderfully well. Then this is evenocumab, angiopoietin-like protein inhibitor. This is a new drug. Again, it reduces 50% of LDL on top of maximum tolerated statins. So again, a new child on the board. Then we have newer therapies, which is called CRISPR-Cas gene editing scissors. They remove the nucleotide and make the gene non-functional for producing, say, PCSK9 or LPA. So they are the latest on board, and this is called one and done. You do this intervention once for lifetime. Dr. Catherson has shown just recently, 2 days back, that CRISPR technology is a reality. They have shown it in primates, and what they show, one-time therapy and you are done for lifetime. Again, it can reduce PCSK9 by 80% or so. This you can do for LPA also. So this is his tweet, which says that chronic disease need not to be treated chronically. Now we are emerging into an era where it can be treated in one go, and it can reduce PCSK9 by 90% and 60% LDL reduction. This is the latest, which has happened 2 days back. So we are, by using these therapies, bypassing the LDL receptor, which had been a foundation for conventional LDL lowering model. So now another way to look at it is zero LDL hypothesis towards extremely low LDL concentration, especially in patients who have high residual LDL. Hypertension cannot be left behind. This is a recent article which has published in Lancet. It shows whether you have cardiovascular disease or non-cardiovascular disease. Sprint-like blood pressure reduction result in event reduction. And this is consequent to that slide. Like lipid, every 5 millimeter of pharmacological BP lowering in 4 years, it reduces 10% CV events regardless of the starting BP. So that is the catch, that if you bring from 130 to 120, you reduce CV events. So coming to the inflammatory risk, out of 4 patients, 3 patients continue to be having an inflammatory risk. Even Fourier has shown that patients who have very ultra low level of LDL, their CRP continues to be a risk denominator. Even at level of 20, if you have high CRP, you have higher event rate. CANTOS, each one of us know, and this is a study to establish a hypothesis whether inflammation is a hypothesis or reality, and a trial showed lower is better, both in inflammation in LDL-C, and what they showed that inflammation is altogether different axis than lipid lowering, although the mortality reduction was not seen in CANTOS. Following CANTOS, we had CERT with methotrexate being failed, and now we are talking of colchicine. The meta-analysis shows there is reduction in stroke, their reduction is myocardial infarction and revascularization, but the cardiovascular death and total death is not reduced. So that is the catch in colchicine therapy, which is upcoming, and it has to position itself because there is no mortality reduction. So once again, when we can make out independent of CRP, this is another vertical axis of colchicine. Coming to thrombotic risk, we realize that out of 3 patients, 1 patient, if we look for so-called stable angina, they continue to throw events. So stable coronary artery disease is a myth like stable heart failure. We have COMPASS study which has combined neurooral anticoagulant like rivaroxaban with aspirin. This is not related to acute coronary syndrome. This is not related to AFib. We are using 2.5 milligram twice a day, and it is in high risk patient. This is the trial design. You all know this works very well, and there is net clinical benefit, even taking into account the bleeding episode. So COMPASS is a new dimension to handle thrombotic risk in coronary artery disease patient. Higher the risk you have, net clinical benefit is more. There is total mortality reduction. And if you place COMPASS, you can find this purple or magenta color that this therapy rivals compete with existing therapy in terms of its efficacy. Unfortunately, it has not hit the clinical prescription pattern in our country. If you look the prolonged antiplatelet therapy, many of the interventionists are concerned about complex coronary angioplasty. There is event reduction, but none of the prolonged antiplatelet therapy has resulted in mortality reduction. So that's how the dual pathway inhibition scores over and above it. This is just yesterday host exam trial. After 6 months to 1 year, patient who had PCI with DES, followed for 3 years, clopidogrel arm versus aspirin. Clopidogrel arm surprisingly has been shown to reduce total mortality and event rate. So it's altogether hot data, gives another dimension. Clopidogrel as a long-term follow-up as single antiplatelet post-PCI patient. They are not coronary artery disease patient who are medically managed. Coming to triglyceride risk, each one of us know reduce it. It's a very strong trial, 2 grams twice a day of omega-3 purified acids. And the good thing which I want to talk about, Many of us feel this is a triglyceride lowering trial. Both walk in and walk out, there was no outcome related to triglyceride. So triglyceride in this trial has shown that it is a residual risk marker. Don't confuse that reduce it is a triglyceride lowering trial. It is not. So now we combine all the therapies. I think we maximally tolerated statin continue to hold the ground, either we combine with ezetimibe or EPA or PCSK9, depending upon the patient profile to address to residual risk. And this is another very good thing you should carry home, that what kind of percentage reduction you want in your patient, whether you need high intensity statin, ezetimibe, PCSK9. And there is another drug called evenacumab, which I will be referring again. Evenacumab also shows up to 50% reduction on top of statin. So that is another player. So newer therapies on horizon. This is a trial which we expect to come, prominent trial, which is pemafibrate, is specifically designed for triglyceride lowering in diabetic patients who are on statin. So let us wait for this trial to understand the triglyceride lowering. And this is again evenacumab. This is inhibition of angiopoietin-like protein 3 with monoclonal antibody. You can see that there is a drastic reduction in triglyceride over a period of 12 weeks. This is valnesorsen, again a monoclonal antibody, very recent trial, had been shown in familial hypercholesteremia, FDA recommendation. It can reduce TG up to 1712 with this monoclonal antibody. So it is familial hyperchylomicronemia. This is not conventional 300, 400 kind of triglyceride. So this is another shot on the board, and we need to use it over a period of time in patients who have very high triglycerides, in patients with chronic pancreatitis. So coming to LPA, LPA you know is a pro-inflammatory, it is pro-atherogenic, and it is pro-thrombotic because it has got LDA and ApoA. So these are Kingals, and you can modify the LPA particle by maneuvering this. The ODC trial has also shown us something very smart signal that PCSK9 inhibitor do not only reduce LDL, but they reduce LPA also, which is not shared by ezetimibe, which is not shared by statin, in fact, increases LPA. So this is a new dimension that ODC trial, the outcome may be related to PCSK9 LPA lowering. We have established causative role of LPA in coronary artery disease. The therapeutic role has to come. So what we have shown with this monoclonal antibody, Dr. Tamaskas is pioneer in his work and shown that up to 98% of the patient can reduce more than 50% of the LPA. And this is the trial, Horizon series of trial, which we are awaiting, that LPA is causative, but whether reduction of LPA results in mortality reduction, that is to be answered. Coming to the last part of my talk about diabetes risk, you know, Amparag and Leader, they are new drugs and vasculoprotective. They should be used in diabetic coronary artery disease patient, and we should not conflict how to choose between the two, but they practically, our patient need both of them. The last two slides are very interesting and very hot. The next dimension is weight reduction. This is a recent trial, step 3 randomized clinical trial, subcutaneous semaglutide had shown 16% reduction, drastic weight reduction over a period of 68 weeks. So this is another dimension. Patients who are suffering from morbid obesity, probably that will be some kind of medical bariatric surgery. Patients who have BMI more than 30 and non-diabetic, 15% weight reduction, losing something like 34 pounds. So this is going to be a very big beginning, and probably how much it can be imitated by oral semaglutide, that is to be seen. So these are the ways we can handle coronary artery disease, the residual risk. They are realities, not fantasy. This is 31-year-old guy who had this disease and left Maine. RCA was not grafted. Patient underwent CABG, AICD, and came back to me after CABG, after I think about 2 years with this RCA. And you'll be surprised to know the surgeon's follow-up was bad. He was maintaining a LDL of 121, and he has to undergo a repeat angioplasty just because of ignorance that LDL in such a young patient is to touch bottom something like 0 LDL or something like 30. So as much as low you can go, what I'm trying to emphasize, these therapies are realities. So I always keep talking, I'm fascinated about and hope for I may be alive someday when we can cure atherosclerosis, and that should be the aim of treatment rather than being stenosis driven. This is William Osler. How I will translate William Osler today: good physician treats stenosis and great physician treats the atherosclerosis. And this is the Dalai Lama. If you think you are too small to make a difference, try sleeping with a mosquito. So ladies and gentlemen, don't think these therapies are small. They are very powerful. They empower you to treat atherosclerosis and probably eradicate atherosclerosis. And in COVID times, I think we need each one of us to be responsible for COVID appropriate behavior. Thank you very much.
Thank you, Rajiv, for an absolutely superb presentation, and thank you for keeping time. I think that Dr. McMurray is waiting, so I will give him the privilege to make his presentation. So maybe we can have...
It's okay if you want to have questions and answers, please go ahead. I don't mind waiting a little longer. It's entirely up to you.
Dr. McMurray doesn't mind staying with Indian friends for a longer time. Last time we started for 1 hour session, ended up in 2 hours. So he enjoys our company, let me say forcibly.
I certainly enjoyed your lecture. It was very interesting indeed.
And I think we'll not keep you this time, sir. I think you can straight away go for your lecture.
For his presentation, and let's introduce him very quickly. He doesn't need any introduction. He's known to the Indian audience, and I don't want to introduce him more than he's one of the most prolific heart failure investigators and scientists. And if you look at his CV, you'll need a day to go through his publications. He's a professor at University of Glasgow, and he's on task force for most of the ESC guidelines on heart failure. So Dr. McMurray is going to talk to us on a very important issue of heart failure and diabetes and the treatment of cardiorenal syndrome. So Dr. McMurray, please.
Okay, thank you very much. So just let me get my slides set up. Here we go. Hopefully you can see my screen and hear me. Is that correct? Good.
Yes, thank you.
So yes, I was asked to talk about reducing cardiorenal risk in patients with type 2 diabetes, and like the last speaker, I've had to try and compress about 5 talks into this rather short talk. These are my disclosures, and because I've had to cover a vast amount of information, I'm sorry, I'm going to have to go through all of this pretty quickly. So let's buckle up to try and look at the amazing amount of evidence that we have. And the reason we have this is because in 2008, the world of diabetes changed completely and utterly. And that was because the US Food and Drug Administration issued guidance requiring the demonstration of the cardiovascular safety of new glucose lowering therapies. Before that, if you wanted to get a drug approved for treating type 2 diabetes, all you had to do was to show it lowered blood glucose. You didn't have to prove anything about cardiovascular safety, let alone efficacy. And for decades, we had no evidence whatsoever to guide us about the value of glucose-lowering therapies in the treatment of patients with cardiovascular disease. But as a result of this new guidance that the FDA put forward in 2008, as you can see here now, there's been an explosion of large cardiovascular outcome trials and indeed kidney outcome trials investigating all of these different novel glucose-lowering therapies. And this is what I'm going to very quickly try and cover. So these are the new approaches that we have to lowering blood glucose. I'm going to start with the DPP-4 inhibitors, and there are 4 placebo-controlled trials with these drugs. I'm not going to talk about this active controlled trial in the interest of time. 4 placebo-controlled trials. They absolutely, overwhelmingly, unequivocally demonstrate that DPP-4 inhibitors do absolutely nothing for the risk of cardiovascular death, MI, or stroke, and equally do nothing for the risk of heart failure hospitalization. Indeed, the very first of these trials actually suggested that one of the drugs in this class, saxagliptin, might even increase the risk of heart failure hospitalization. So before we move on to the glucose-lowering therapies that are beneficial in patients with cardiovascular and renal disease, we have to recognize that there is an incredible paradox that really should probably shame all of us, and that is that despite the fact that these agents don't do any good for cardiovascular kidney disease, they are by far the most commonly prescribed of the new glucose-lowering therapies. So what about the agents that do some good? Well, let's look at the GLP-1 receptor agonists. You heard a little bit about those in the last presentation. So there are a whole family of injectable GLP-1 receptor agonists. And as you can see here, there have been a large number of trials with these agents. All of these are now completed. We haven't seen the results of one of them, the Freedom trial, which was actually really a test of a new device for infusing one of these agents. And this trial that I was fortunate enough to co-lead, the agent that we use sadly is now no longer marketed. There is also a very, very important innovation in this field, which is that one of these agents is now available as an oral drug, so not an injectable, an oral drug. And in fact, the first moderately large trial with the oral formulation of semaglutide, the Pioneer 6 study with over 3,000 patients, remarkably showed a highly significant and substantial reduction in cardiovascular death. Now, there weren't many events in this trial. I think we have to regard this as still hypothesis generating, but very, very encouraging data with this oral formulation. I'll come back to that in a moment. But if we put together all the GLP-1 receptor studies in a meta-analysis, then we can see that these agents do seem to reduce the risk of cardiovascular death, do reduce the risk of myocardial infarction, and seem to be most effective in terms of reducing the risk of stroke. We really don't have good evidence that they reduce the risk of heart failure. And there's a lot of discussion that I haven't got time to go into that different agents in this broad class, which is really 2 distinct types of therapy, there may be differences between these agents, but they do reduce atherothrombotic events. And there is some suggestion that they may also improve renal outcomes. Now, this is largely based on what I would call soft outcomes. So this is reduction in urinary albumin excretion, reductions in creatinine, improvements in EGFR. There is no evidence that these drugs reduce the risk of hard outcomes such as reduction in dialysis or need for transplantation, but at least some evidence that they might be doing good things to some surrogate renal endpoints. But we are going to get lots of evidence about these drugs. So you can see that there is a huge trial underway with the oral formulation of semaglutide in patients with type 2 diabetes who've got cardiovascular or renal disease. So this is a trial that will tell us about cardiovascular and renal outcomes with the oral formulation of this GLP-1 receptor agonist. There's another enormous trial looking at this drug, the injectable formulation, obese, overweight patients who don't have type 2 diabetes. There is a large trial looking at whether or not this agent might improve hard renal outcomes. That's the FLOW trial. And there are a number of other studies, but maybe one to look out for is, believe it or not, another cardiovascular outcome trial with a different agent in this class, a long-acting agent given once weekly, and the Amplitude O trial will report this year, I believe, very shortly, next month, at the American Diabetes Association. And then there are other new agents that are related. There is a new drug that is a dual GIP and GLP-1 receptor agonist, and is already being investigated in an enormous 12,500 patient cardiovascular outcome trial. So lots of new things happening in this space. But what I want to spend the remainder of my talk talking about is the SGLT2 inhibitors. I think you all know about these. They act in the proximal renal tubule to inhibit reabsorption of filtered glucose, and they really have proved to be a revolution in medicine, in diabetes, in cardiovascular disease, and in nephrology. So let's look at the role of these drugs in preventing incident kidney disease in patients with type 2 diabetes. And we've got 4 large outcome trials that tell us about the effect of these drugs. And you can see a brief summary of these trials in this table. 4 different agents, all large trials, all primarily designed to look at reduction in cardiovascular events. But each of these trials also tells us about renal outcomes. Now, again, these are largely soft endpoints, largely looking at changes in eGFR and in urinary albumin excretion, although there are patients who do progress to end-stage kidney disease. Collectively, these trials certainly suggest that SGLT2 inhibitors in a broad spectrum of patients with type 2 diabetes who largely have relatively preserved kidney function at baseline, these drugs do reduce the risk of incident kidney disease. And this is an example from one of those trials, the DECLARE TIMI 58 trial. So these are patients with these are patients with type 2 diabetes and largely just cardiovascular risk factors. And you can see the steady decline in eGFR over time, almost linear decline in the placebo, the conventional therapy groups. And you can see how this decline is slowed in the SGLT2 inhibitor group. In fact, these eGFR slopes cross over after about 2 years of therapy. But what about the use of these drugs, not to prevent incident kidney disease, but actually to treat prevalent chronic kidney disease in patients with diabetes and without diabetes? In other words, can we also use these drugs to prevent hard renal events, end-stage kidney disease in patients with established renal failure? And there are 4 large trials that have tested or are testing these drugs in patients with established chronic kidney disease. 3 of these are now completed. 1 is currently ongoing, but I believe is now fully recruited. The first of these trials to report was the CREDENCE trial. So patients with type 2 diabetes and nephropathy You can see here where the patients lie in this heat map. You can see that their average EGFR was 56 mils per minute, much lower than in those other cardiovascular outcome trials where most patients had relatively preserved kidney function. So an average EGFR 56 and a substantially elevated excretion of urinary albumin. And as you can also see down here, the number of patients having requiring renal replacement therapy, so either dialysis or transplantation, you can see 10 times as many of these events in this trial as in those earlier studies. So these really were a completely different group of patients. And you can see that whether you looked at the primary composite endpoint, whether you look at the individual components of that composite endpoint, or whether you look at the hardest of these renal composites, so dialysis, kidney transplantation, or renal death, you can see that they are all reduced significantly, including this. The 95% confidence intervals here do not cross 1. No question that SGLT2 inhibitors reduce the risk of kidney failure and the need for renal replacement therapy in patients with type 2 diabetes and chronic kidney disease. But what is more remarkable is we now know that these drugs can do that even in CKD patients who don't have type 2 diabetes, because in the DAPA-CKD trial, we enrolled patients with and without type 2 diabetes. We presented this trial last year. Here you can see where the DAPA-CKD patients lie on the heat map, and even lower EGFR, similar elevated excretion of urinary albumin. Again, a large number of hard renal events, 178 people requiring renal replacement therapy, and once again, a striking reduction in the primary composite endpoint, a 39% relative risk reduction, enormously statistically significant, very small number needed to treat, and an entirely consistent benefit in patients with type 2 diabetes and also in patients without type 2 diabetes, a 50% reduction in the primary endpoint in CKD patients without type 2 diabetes, and even in this trial, a reduction in all-cause mortality. Now, in cardiology, we're spoiled. We're used to saying that. Believe it or not, this is the first time any drug has been shown to reduce mortality in patients with chronic kidney disease. So basically, we know that these drugs both prevent and treat chronic kidney disease in patients with type 2 diabetes, and indeed in those without type 2 diabetes. What about SGLT2 inhibitors for preventing cardiovascular events? Well, I'm going back to these 4 large cardiovascular outcome trials. Again, you can see here a mixture of patients with established cardiovascular disease or a mix of cardiovascular disease and cardiovascular risk factors. And in each of these trials, the primary endpoint was so-called MACE, cardiovascular death, MI, or stroke. And then these trials also reported the composite of cardiovascular death, or heart failure hospitalization, and heart failure hospitalization alone. And what was most striking about all 4 of these trials is the consistent, large reduction in risk of heart failure hospitalization. What was, I think, and still is a lot less clear, is whether SGLT2 inhibitors prevent atherosclerotic events. We've seen that GLP-1 receptor agonists do, but I think it's not clear whether SGLT2 inhibitors do. If you put all of these trials together, then there is a small and statistically significant reduction in major adverse cardiovascular events, although I think it's probably largely driven by a small reduction in cardiovascular death if you put all the trials together. And in turn, I think that is probably primarily driven by reduction in heart failure mortality. Now, I know other people take a different view, and some people do believe that these drugs might reduce at least myocardial infarction, but I think nobody would argue that these drugs reduce the risk of stroke. And if you remember, it was the risk of stroke that was most clearly reduced by GLP-1 receptor agonists. We've also studied whether SGLT2 inhibitors reduce the risk of cardiovascular events in patients with chronic kidney disease, because of course, all of those renal trials that I've just mentioned also reported cardiovascular events. And in the interest of time, I'm not going to go through each of these, but just to say that all three of these that have reported have all shown large and significant reductions in heart failure hospitalization of the order of 30 to 50% reductions in heart failure hospitalization in these CKD trials. So finally, what about using these drugs to treat heart failure? So I showed you that striking reduction in incident heart failure, prevention of heart failure. What about treatment of heart failure? And again, we've got very strong evidence. We've got 2 trials carried out in ambulatory patients, patients with heart failure and reduced ejection fraction. Both of these showing this consistent 25, 26% relative risk reduction, the primary composite endpoint of cardiovascular death, or essentially heart failure hospitalization. Again, highly statistically significant, large relative as well as absolute risk reduction, a number needed to treat of only 21 over a median of 18 months to prevent 1 patient having fatal or non-fatal heart failure events. And again, you can see here this very early onset benefit documented in each of these trials to occur within just 1 month of starting treatment. And again, this benefit now extends beyond patients with type 2 diabetes. I know I was talking, my remit is to talk about type 2 diabetes, but just like SGLT2 inhibitors are beneficial in CKD patients with and without type 2 diabetes, it is also the case that SGLT2 inhibitors are beneficial in heart failure patients with and without type 2 diabetes. The benefit is entirely consistent in patients without type 2 diabetes. It's got nothing to do with glucose or glucose lowering in these patients. And indeed, we now have a 3rd trial, don't really have time to talk about, again, showing an entirely consistent benefit. And it's rare that you get in such short order 3 trials, each demonstrating such a consistent and clear benefit. So these drugs are now really part of our foundational therapy for the treatment of heart failure with reduced ejection fraction. And very shortly, we're going to see the first of the large dedicated HFpEF trials, almost 6,000 patients with heart failure and preserved ejection fraction in the Emperor Preserved study. This will present at the European Society of Cardiology Congress later this year. And finally, I want to just remind everybody that there's been another important breakthrough in the treatment of patients with type 2 diabetes, those who are at greatest risk by virtue of having chronic kidney disease, and that's the demonstration of benefit with a new type of mineralocorticoid receptor antagonist, a drug called finerenone that is described as a non-steroidal mineralocorticoid receptor antagonist, believed to have less risk of causing hyperkalemia. And this has been studied in 2 trials in patients with diabetes and chronic kidney disease. The Fidelio study, which was published last year, October, where the MRA, finerenone, reduced both the risk of the primary composite renal endpoint significantly by 18%, and also reduced the risk of a secondary cardiovascular composite endpoint, you can see here, by 14%. And then recently we've seen more, these are data just presented a few days ago at the American College of Cardiology, more evidence of benefit this time in the reduction of new onset atrial fibrillation with finerenone in the Fidelio DKD trial. And then last week, we got news that the second of the two trials in this program, the Figaro DKD trial, a very similar patient population. In this trial, the primary endpoint is the cardiovascular composite, so the same as the secondary endpoint in Fidelio. We got news in a press release from the sponsor that this trial is positive, that there was a reduction in the primary composite endpoint with finerenone in these patients with type 2 diabetes and chronic kidney disease. So really good news for patients with chronic kidney disease. So these are my take-home messages. We've seen these really stunning recent breakthroughs in the prevention, treatment of renal and cardiovascular complications of type 2 diabetes. We've seen that SGLT2 inhibitors reduce the risk of developing heart failure, reduce the risk of developing kidney failure, and they can also be used to treat established heart failure and established chronic kidney disease, even in patients without type 2 diabetes. We know about HFrEF so far. We're going to find out about HFpEF later this year. I said that I personally don't believe that SGLT2 inhibitors have much effect on atherothrombotic events. They have a very large effect on heart failure and kidney failure, but I don't believe such a striking effect on atherothrombotic events. But GLP-1 receptor agonists do reduce atherothrombotic events, especially stroke. I don't think they directly reduce the risk of heart failure. We don't know yet about their effect on kidney disease, although this is under investigation. And just to remind you, next month we will get another large trial with a different agent in this class reporting at the American Diabetes Association. And finally, I concluded my presentation by mentioning these two large new trials with finerenone, and the second of these, Figaro, will present later this year, again at the European Society of Cardiology Congress. So with that, I'd like to stop and thank you very much indeed for listening to my presentation.
Thank you very much, Dr. McMurray, for an absolutely wonderful and precise presentation of all these important trials, which we've seen in the last few years in the treatment of heart failure, cardiovascular disease risks, and kidney disease. I really think that we've got two areas which we still need to have some data, and one is the preserved ejection fraction, and the other is acute myocardial infarction in many of these trials. And it was a bit disappointing, the Paradise-MI in ANIs versus the ACE inhibitors. And so what do you think, what's your crystal ball for preserved ejection fraction and acute myocardial infarction of these drugs?
Well, preserved ejection fraction, my crystal ball is more optimistic than it used to be, because I didn't really have time to talk about the SOLOIST trial with sotagliflozin and the SCORED trial, which was the chronic kidney disease trial with sotagliflozin. Between those two trials, there were over 750 patients who had heart failure with preserved ejection fraction, and the benefit of sotagliflozin seemed to be as large in those patients as in patients with a clearly reduced ejection fraction. So not definitive data, but very, very encouraging. And I will personally be quite disappointed if we don't see a benefit in the Emperor Preserved study. Normally, I'm worried about trials with HFpEF because we've just had no success before. But I have to say, with this class of drugs, I'm much more optimistic than I normally am. In terms of acute myocardial infarction, I think that's much more challenging. So personally, I think SGLT2 inhibitors predominantly protect against the development of heart failure. And therefore, it's really essential that the population that's targeted is one that is at high risk of heart failure. And of course, that's relatively challenging in the modern era of acute myocardial infarction, because clearly with primary percutaneous coronary intervention, coronary reperfusion therapy, you reduce the risk of substantial left ventricular damage, and the incidence of heart failure is less than it used to be. And therefore, unless you're very careful in the population you enroll, and it's not really enriched for risk of developing heart failure, then it might be hard to show a benefit. On the other hand, if you do think carefully about the patients that you might wish to include in the trial, if you, for example, include patients who have persistent remaining left ventricular systolic dysfunction after their infarct, and so on, and there maybe are other heart failure risk enhancing variables, then it may be possible to demonstrate benefit. Now, there are two large ongoing trials with SGLT2 inhibitors. One has taken the approach I've just described. The other is enrolling a much broader population of patients after myocardial infarction. So again, we'll get an answer, but I'm less certain about what that answer might be, certainly in the second of those trials with the much broader inclusion criteria.
Ambrish, any comments?
No, I think we've heard Dr. Murray, hello sir, many times, and he's again very clearly brought out the importance of newer drugs in management and actually prevention of complications of diabetes, particularly related to the heart. I think it's a very crisp and concise presentation, and we welcome any audience questions, which there must be. So, these are actually very general questions. They're not necessarily related to the topic. It's for the cardiologists. Maybe I should just take them. What should be the next step in patients who present with non-specific chest pain, ECG done showing non-specific ST changes? Should we ask for echo or dobutamine echo or troponin?
I think that you need to have a triage in the emergency room. So you have an atypical chest pain, but you have a clinical risk profile which is high. I think you need a troponin at 0 hours, 1 hour, or repeat EKG, and then decide whether this is cardiac or non-cardiac, and then make a decision how to treat the patients. Well, obviously, you need to also rule out things like pulmonary embolism and aortic dissection when patients present with chest pain in your ER, which you're not sure whether this is typically cardiac or not. I think an echo is useful, but you need to have good technical support in the ER. In India, it's okay, but in most of the Western world, echo is not used so much in the triage for chest pain. It's more an EKG, troponin, and maybe a CT scan in many of these patients, but we use it routinely for our triage in the emergency room. I don't think there's a room for dobutamine echo in an acute chest pain. I think that's, more for a chronic outpatient clinic, and I would possibly simply deal with EKG and troponin, and then make a decision of whether we need anything further in these patients.
I think there are other questions, but there are very specific case-related questions, so we'll pass them for the moment. Just like to thank Dr. McMurray for a wonderful presentation as usual. the fact that the management, the whole approach to diabetes started changing in 2008, as you very rightly pointed out, but over the last 5 or 6 years, it's completely gone on its head, so to speak, because we're really not looking at glycemic control alone anymore. And the choice of drugs is determined very significantly for us endocrinologists by existing comorbidities. And the power that SGLT2 inhibitors and to some extent GLP-1 RAs have provided us to help our patients in terms of protecting them or reducing their risk of long-term cardiac as well as renal issues has changed the game completely. And I think these are exciting days, and more new information is coming generally in the right direction. So we're very encouraged by this change in management, the whole approach. And as I keep saying, that diabetes is not just blood glucose. The blood glucose is like an index parameter which tells you about the overall metabolic health of the individual. These people who come to you just for diabetes would have multiple things either evident or hidden. And you have to look at the patient as a whole and really manage long-term risks. Who really cares if the blood glucose is not doing anything? Let for a moment, if one lives through their lives with 300 milligram blood glucose and nothing happens, then one is really not worried. But the reason is that blood glucose, when it's partnered with so many other things, it really can impact the long-term morbidity, mortality, everything. So I think it's very important to take a holistic view, and we are very glad that that is happening. And cardiologists and endocrinologists and now nephrologists and even hepatologists are all coming together to treat patients as a whole. And you drove that point home very nicely, sir, as usual, and with excellent, crisp presentation and points. Thank you. So we're going to talk a little bit about vaccination. So the reason, and I'll give some background. Of course, we have panelists for this. In addition to Dr. Ajit, we have Dr. Vijay Kher. Dr. Vijay Kher, of course, I really don't need a slide for him, but nevertheless, he is the chairman of nephrology and renal transplant medicine at Medanta. He has done many things in life, including trained a large number of students who actually provide nephrology services across the country. And in addition to all his other achievements, I think his singular biggest achievement is the fact that he has set up transplant programs at several different institutions, kicked them off, done all the hard work, and then given it to others to run. So his academics and brilliance is well known. We welcome Vijay Kher to this panel. Then, of course, I have my young friend, Vagesh Iyer, who is the professor and former head of endocrinology at St. John's in Bangalore, the prestigious St. John's. He's done everything with Karnataka Endocrine Society. He's been a treasurer of the Endocrine Society of India, RSSDI, very active in the Endocrine Society, I must say, and lots of involvement in clinical trials. So we'll share your experience, Dr. Kher and Vagesh, and I'll be very happy to conduct this and get the ball rolling so that, So when we, and of course we have Dr. Ajay Naik, and Ajit, you want to introduce Dr. Naik? Hi.
Dr. Ajay is a very well-known electrophysiologist from Ahmedabad. He's a Bombay colleague of mine, and he is well-trained in multiple areas, especially in the EP area. He's the past president of the Indian Society of Electrocardiology and the Indian Heart Rhythm Society, the past vice president. So Ajay, we look forward to a good interaction in the areas of vaccines for cardiometabolic disorders. So please go ahead, Ambrish, we can go ahead with the session.
Thank you, Ajit. And we'll spend about 15 minutes today talking about vaccines, and not into the immunology part of vaccines really, but as clinicians who deal with patients, what do we do with our patients in regard to vaccination? The whole chapter has been opened up because of COVID-19, which is engulfing us in so many ways, actually. We all know that people with comorbidities like diabetes, heart disease, chronic kidney disease, even hypertension have clearly poorer outcomes with COVID-19. Our own data, which we published earlier, showed that out of 401 consecutive patients, mortality or morbidity was significantly higher in those who had multiple comorbidities. Again, the same point, if you sift out each comorbidity separately, the impact becomes much less. The moment you put them together, the impact is much higher, both on morbidity and mortality. And that's, we have seen, I mean, the mortality in people with diabetes and comorbidities is easily 4 or 5 times higher. And when you have CKD, it really exponentially increases with COVID-19. So one of the questions I will ask, and this is more for all our colleagues, there are more than 3,000 odd people listening to us. Is there any contraindication to use of COVID vaccine in people with heart disease? Dr. Naik, please. Do you think people with heart disease have to be extra cautious about their COVID vaccination?
I would put it the other way around. Patients with heart disease are at the highest risk of severe morbidity and mortality if they contract coronavirus and get the COVID disease. So patients with cardiac disease, in fact, should be well protected and they should be given the vaccine. That is the only armament we have in prevention against this disease effectively. So I have almost never refused the vaccine for any of my cardiac patients. The only issue sometimes comes up with is my post-heart transplant patients, where we have to be a little judicious as which vaccine to advise. We don't have a choice now, and when to advise it. But otherwise, any other cardiac issues, I've never refused a vaccine. In fact, I've told them that you should get vaccinated.
So, Dr. Naik, one question that keeps coming to me and to everybody, and I would like you to clear it for all our viewers and listeners, our medical colleagues. I'm sure they're asked the same question 6 times a day. What about blood thinners? And blood thinners has become such a vague term. It includes antiplatelet therapy, it includes anticoagulants, everything. So what about people on blood thinners? Are you concerned about using the vaccine or any particular vaccine in them?
No, this is a very pertinent question, and that is the first thing which comes up in the mind. There are published guidelines, especially from the Hematological Society. If patients are on antiplatelet agents, you don't need to stop the antiplatelet agents. You can go ahead with the vaccination. If the patients are on oral anticoagulation, if they are on warfarin, then you need to check the INR prior to the vaccination. If the INR is less than 2, go ahead with the vaccination. If it's less than 3, go ahead with the vaccination. If it's more than 3, you wait, hold the drug, repeat the INR after a couple of days. The moment it falls below 3, you can go ahead. The only concern here is intramuscular hematoma. That is the only thing we are worried about patients on anticoagulation. And so it's advised that you take it with the vaccine is given with a thinner needle 23G needle, and just give a little more pressure for a longer while, and that should be it. Patients who are on NOACs, novel oral anticoagulants, you just hold the dose for that day, take the vaccine, and take the dose after that, or to be on the safer side, you could take the day after. So apart from intramuscular hematoma, there is really no concern as to why the vaccine should not be given or should be held with these patients.
So I think those are very important points. I know this common knowledge to this panel, but people still have those doubts. And really the only risk is an intramuscular hematoma, nothing more than that, nothing to do with the COVID or the heart per se. So thank you for clarifying that. I'll move to you, Dr. Kher, and you have a huge chunk of renal patients, perhaps one of the largest groups in the country, especially post-transplant. So there is always this fear with COVID-19 that, should patients with kidney disease get their vaccine or not? Number one. Number two, what about those who've been transplanted and who are on immunosuppressants? You want to clarify those points? Dr. Kher, please. Oh, something happened.
So I think Dr. Kher has lost the connection.
So I'll come to Vagish and come back to the question will remain. Vagish, this morning also, I got a call from a patient saying that they were refused. I'll come back to you, sir. 1 second. Dr. Kher, give me a second.
Yeah.
So I got a call from a patient saying that they were refused vaccination because their blood sugar was 210 fasting. And they were told that you come back with a normal blood sugar to get your vaccine. So where do you put COVID vaccination in the context of diabetes?
I think they should get the vaccination done irrespective of the blood glucose levels, because the protection offered, some amount of protection definitely comes, though we say that uncontrolled glucose to some extent may compound the immune challenge. But recently, I think this month only, the JCM article came. There's a COVID and COVID vaccination and diabetes. What they have found is there is no difference in the patients who had a blood sugar, means they diagnosed only diabetes and a non-diabetic. The amount of immune response was almost similar. In fact, I would have told, go ahead and take. We'll wait and see what happens, because protecting from COVID is much more higher challenge than delaying their vaccination.
I totally agree, Vagesh. And the important thing here is that it cannot do any harm.
Yes.
If the blood glucose is a little bit high. Maybe there's a slight difference in immunity in someone who's very poorly controlled, yes. But that will not, the vaccine will still not cause any harm. Maybe it'll be slightly less effective, we don't know, but it'll not. So I think that's very relevant. But somehow these things still are happening, despite the vaccination being more than 3 months in the country, these questions still arise. What about type 1 diabetes, Vagesh?
Type 1, I think 18, just they have been launched from 18 to 44. Somebody is above 45, yes, go ahead and take. Fine. Yes, please. So that's
18 to 44, if you have type 1 diabetes, is there any...
Prioritize in giving them.
We should do that. So we go back to Professor Kher with the same questions about your patients with chronic kidney disease, who we know are generally not very healthy and overall immunocompromised, but especially if they've had transplants, of which you have a large population. So what are you advising them?
Yeah, I think as Amrish, you said that patients with kidney transplants, if they get COVID, they are 20 to 30% mortality in them. So 100 patients with kidney transplantation, if they get COVID, 30% of them will die because of COVID. So it's all the more important for these patients to get vaccinated. In fact, we are requesting the government that these patients should be prioritized for vaccination, and they should be put on a high priority for vaccinating. Above 18 years, everybody with kidney transplantation should be vaccinated. Whatever vaccine they might get, it shouldn't matter at all. All vaccines are equally effective. And I think it's been shown that in transplant patients, the immunological responses may be lower, but even those patients who have been vaccinated, even when they did not have the antibodies, the COVID infections weren't as severe as in those patients who are not vaccinated. So vaccination is an extremely important step in preventing COVID infection. And for that matter, vaccinations and transplantations are important events for preventing many other infections like pneumonia and flu, which can again cause severe morbidity as well as mortality in patients with transplantation. The same is true for patients with moderate to mild kidney disease. These patients are again at high risk of mortality. Again, 20 to 30% mortality in comparison to 1 to 2% mortality in non-CKD population or general population who do not have that much of comorbidity. So these patients again need to be highly prioritized for providing vaccine to them. And we are again requesting government, like you are requesting governments for patients with diabetes and other comorbidities to get prioritized for vaccination. These are again patients who need to be prioritized for vaccination. The responses again may be on the lower side, but they are much better than not having a vaccine at all and not having any immunity.
So again, the same point being driven home, that you may have a slightly poorer response, but it can't hurt. You know, it can only help. Maybe it'll help a little less than in someone who has a very good immune system, but it will still help. And since you're so vulnerable, those groups are so vulnerable, it's really important that we don't ignore them. I'll actually just pass one question each to all of you now and end after that. But that's an important question. So let me start the other way with Dr. Kher himself, because I know Dr. Kher has been a very strong votary of vaccination. I remember him using vaccinations in his prescriptions like 20 years ago, when no one else was talking about vaccinations so much, adult vaccinations. Dr. Kher, what vaccinations do you normally advise to your patients who have, forget the transplant ones, for regular CKD patients, adult patients, what vaccinations do you advise?
Yeah, I think Amrish, you said it very right that we've been vaccinating our patients for long periods of time, especially hepatitis B and C was very common in patients of chronic kidney disease. These were diseases which happened in these patients. They used to be in the hospitals more often, and therefore they got exposed to hepatitis B and C. Therefore, for hepatitis C, unfortunately, we don't have a vaccine still. But hepatitis B vaccination should be done in patients of chronic kidney disease as early as you detect. Fortunately, now hepatitis B vaccination is provided to children who were born recently, but those patients who were not vaccinated, we should vaccinate them for hepatitis B. And these are given, 4 doses are given, double the dose than a normal person. And we do 3 monthly and 4th, 6 monthly dose for patients of chronic kidney disease. Their antibody response again is lesser in comparison when we have used, and you know about our research about giving adjuvants in patients with hepatitis B like GM-CSF also, and high dose vaccinations being given to them to improve their immunity. We give pneumococcal vaccine. We give flu vaccines every year. Pneumococcal vaccines are given both conjugate as well as polysaccharide vaccines are given in patients of chronic kidney disease because they're considered to be immune compromised. And therefore, we do separate them 2 months. We give conjugate first and then give a polysaccharide 2 months later. But if the patient has already taken polysaccharide, then we usually wait for 1 year before we give a conjugate vaccination. And then every 5 years we do. But in patients of chronic kidney disease, many times their antibodies might go lower. 3 to 5 years may be the way to protect them from pneumonia if you repeat these polysaccharide vaccinations again on them. We also give herpes zoster recombinant vaccine in our dialysis population prior to. We would want our patients to get immunized and given vaccinations prior to transplantation, because after transplantation, many of these patients are going to be on immunosuppressive drugs, and they're not going to be able to get vaccinations at least for 6 months when the immunosuppression is high. It's only after their immunosuppression has been lowered, which could be 3-6 months or maybe a year or so in some of these patients, then only one might be able to give vaccinations. And obviously, live attenuated vaccines are not given in post-transplant period, and they should be given also very carefully in patients of chronic kidney disease or end-stage kidney disease.
Fantastic. I think those are very, very valuable pearls of wisdom for all young nephrologists and people who treat kidney disease. I will ask a question to Vagesh, and then I'll have to ease out, and I will leave the last discussion for the cardiologist to close the session. So Vagesh, what is the formula you are following, the guideline you are following in your practice for vaccinating adult type 2 diabetes?
In fact, somebody above the age of 50 years, probably we recommend ask them to take, but the number is very, very less. It's a very, very less number who take it. Mainly the educated who are lot of knowledge about the vaccination, especially the children who are abroad and all, they are motivated to take a vaccine. Otherwise, general population, it's quite less. It's a very, very small number. Even if we offer, the number who take it is very less.
So I agree with Vagesh. We've been in the last few years really pushing vaccination, yes, especially those above 60. 65 is the cutoff, but we think Indians get diseases earlier. So above 60 for vaccination. It is a bit of a challenge, but I think the acceptability is increasing, and I think we really need to launch a campaign through the Endocrine Society in the same way as nephrologists have done to encourage vaccination, and using COVID as the handle, maybe we can convince more people, yes, to go into vaccination. That really requires a lot of effort on our part, but it will be a worthwhile effort because we can really help our patients. I will unfortunately have to ease out. Ajit, I give you Dr. Ajit Mulasari, the podium, as I said, or the platform, whatever it's called, these days. I give you the mic and please carry on, and we need to discuss the cardiology part and whatever else is left. Thank you.
Thank you, Ambrish. And I'll just ask Ajay a very simple question, which we all face the same way, like the nephrologist and the diabetologist, is what patients of heart failure, do you advise a routine vaccination, the flu and the pneumococcal, do you advise it to all, and what is your uptake of these vaccines in practice?
Oh, absolutely, Dr. Mulasari. We are extremely aggressive with vaccination in patients with heart failure, any kind of structural heart disease, if there is coronary artery disease, post-procedures, or patients who have undergone bypass surgery, valvular heart disease, even congenital heart disease patients. So most of these patients will we advise pneumococcal vaccine and influenza vaccine that has to be taken once a year. So what we used to see till almost 7-8 years ago, when the vaccination was not that prevalent, that every winter patients of heart failure would get admitted with pneumonia, with bronchitis, and the morbidity mortality was very high. But the moment we brought this into our protocol, that all heart failure patients should get this vaccination, the need for admission, hospitalization, and pneumonia incidence went down dramatically, and it was really good outcome, good way of taking care of these patients.
I think I agree with you, Ajay, but it's the same issue like everything else. Yes, the heart failure patients do get vaccinated much often, but the routine stable coronary artery disease patients and the bypass patients sometimes are hesitant even when you advise. But we need to tell them clearly that the protection is huge in these group of patients.
Right.
And I think we need to drive down that point like the nephrologists have done and what everybody else is saying to tell. And I really think that sometimes the cardiologists forget about vaccinations. And we need to have somebody who's bringing the vaccination story aggressively on the table for these cardiac patients. So I'd like to just sort of put it to all the three panelists now that in this current pandemic, which is going on, has your other vaccination programs like the flu and the pneumococcus and everything else got a hit in the whole thing? Have we just forgotten all those vaccines and we're just worrying about COVID and COVID and COVID, and we're not looking at something else? Is there a problem like that happening?
So if I may come in here, the way I do it is in all my patients, and even at our center, we have a checklist. And in our heart failure clinic, this is always reinforced in our patients. And we tell them that every October at Diwali time, they should get the influenza vaccine. And that should be done before the winter onset. And this is driven home at every follow-up visit. So even if they are not able to come and see me, or they are not able to come to the hospital, wherever they are in the peripheries, in the regional areas, they remember that Diwali means influenza vaccine has to be taken. That is what I have driven home the point.
How do you look at it?
Yeah, no, I think I would agree with Dr. Ajay that we have put also a checklist. Every time a patient comes, we check whether the patient has been vaccinated for hepatitis B. We also monitor their antibody titers every year, because they lose the antibody titers much more quickly than the normal population. So we do check them, and in patients with chronic kidney disease, especially dialysis patients, we would want the antibodies to be more than 100 rather than the 10 international units which have been recommended generally, because our patients are exposed to the blood products as well as to lines getting infected, and cross infections can occur in the dialysis unit. So therefore, we do check their antibodies, and if their antibodies go down, we would give them a booster dose for hepatitis B. We do same way for Diwali. For our patients also means a flu vaccine, and then they also get pneumococcal vaccines every 3 to 5 years, polysaccharide booster every 3 to 5 years. Yeah, those are the kind of things we do. And prior to transplantation, we have a checklist for whether the patients have been vaccinated, and we would use a window prior to their getting transplanted, that we would try to vaccinate them for all the vaccines which are possible to be given to them. Especially herpes zoster is picking up now. We were not doing it before, but now we find that if the the antibodies are not there, IgG is not there, then we would give a herpes zoster recombinant vaccine, 2 doses prior to transplant. But however, if they get transplanted and then they have not been vaccinated, and if they are at high risk for developing herpes zoster, then we would give them a recombinant herpes vaccine as well.
Any comments, Vagesh, finally, on diabetic patients?
Yeah, I think our patients are not as accepting as the patients with heart failure and a transplant, because they haven't suffered any event. I think pushing them is quite difficult. It's a quite difficult task. Yes, I think you are at a much easier place to push them for a vaccination than what we are at.
Yeah, I agree with you, and I think that sometimes primary prevention is more difficult when patients have disease states, where you can push many of these secondary prevention programs harder in these patients. So I think we had an excellent discussion. We cleared out most of our doubts of COVID vaccination, of influenza vaccination, pneumococcal vaccination, herpes zoster, and hepatitis B, which are the common vaccines we need to all know about. And we should not forget these vaccines in the COVID pandemic. And I think we should all be alert that these may surface when in the confusion of COVID. And we should not forget that. I'd like to thank all the 3 panelists for an excellent program and putting in your comments, which are very relevant for the people attending the meeting. I understand there are 7,000 plus registrations and about 4,000 plus attendees. So I would like to thank ITAS for giving us this platform to discuss many of these very, very important issues, right from diabetes to coronary disease to heart failure to immunization, which we are all talking today and important for our practice today. So I'll hand it over to Dr. Dixit from ITAS. Dr. Dixit, please go ahead.
So it's in my privilege to propose a vote of thanks on this occasion. And what I can say that it was indeed a very insightful scientific meeting, starting from the diabetes management into the phygital way to the management of the young MI. And what I learned today is like that the angina is also having a more prognostic value than the ischemia. And of course about the wonderful insight on all the adult vaccination. So with this, I must mention our deep sense of appreciation for our course director, Dr. Amrish Mittal and Dr. Ajit Mulasari sir, for formulating and conducting this distinct scientific program. I would like to also express our sincere thanks to all the faculty members, starting from Dr. Chaudhary, Dr. Taini Nair, Dr. Agrawala, Dr. Vijay Kher sir, Dr. Vagesh Iyer sir, and Dr. Ajay Nayak for their contribution and the expert insights. And special thanks to the Professor McMurray for providing us the valuable insight on the reducing cardiovascular and the renal risk in the type 2 diabetic patient. And finally, a big thank you to all the attending clinicians. As sir has said, we have crossed the 7,000 mark in terms of the registration, and the 4,000 clinicians are live who are watching us and sparing their valuable time. If you like our program, you can write us in the comment box. That will be very helpful to us. And my sincere thanks to all the members of the Cross Connect organizing team who have worked so hard to make this program successful. I would also like to thank our studio partner for their continuous technical support. And with the wish and hope of brighter and healthier future, I would like to say goodbye to everyone. Thank you. Thank you. Stay safe. Stay well.
Thank you. Thank you.
Thank you.
Good night. Thank you.
Thank
Bye-bye.
you. Thank you.
Bye-bye.
Thank you, sir. Thank you.